There's a big difference between filling to balance and filling to fill.
Yeah. Oh, that's a great way of putting it. Yeah.
And many injectors, many beginners, many patients, in fact, are looking at areas. Artistic injectors are looking at the harmony of the face, how one impacts the other. It all comes down to detail.
Yeah.
Detail appreciation in any industry distinguishes good from great.
Yeah.
And to understand detail and proportion, you need to really appreciate where things are lacking.
Yeah.
It's like filling in the dots. I had a patient yesterday who they came in for teardrop filler. I could have said yes and do it. I could have just said no.
Yeah.
What I did really was give her the option and explain why she's not suitable. I think if you can explain why something,
they appreciate that.
They appreciate it.
Yeah.
So I looked at the skin quality. This is why I say the customer is not always right.
Yeah.
You come to me with the class 2 profile, I'm not doing your lips, I'm doing your other third.
Yeah.
That's how you harmonize it.
Let's talk about the male market.
The male market has shot up. 2 things have triggered it. Number 1, dating apps, and something called Looksmaxxing. We know statistically that men are being screened out if they don't earn enough, if they look a certain height, if they look a certain way, if they're not.
Yeah.
So it's called the black pill movement. I think the key thing here is with these younger Looksmaxxers, some of them start very early, is recognizing the distinction between what's obsessive and abnormal and being quite realistic.
What steps can a male viewer going to get injected, or what kind of things can they watch out for to know, oh, don't inject too much in this place, or make sure you do this and this, etc.
Or what suits a male proportion, essentially. What's a male proportion guideline?
Yeah. Welcome back to Dr. Abs podcast. Today I have with me one of the most prolific dermal filler injectors in the world. Right now, dermal fillers are in the mainstream media. A lot of people are talking about them for good reasons and bad reasons. Who better to invite onto the podcast to talk about this than someone who does possibly the most full face filler cases in the world. There are clinics that do a large amount with a lot of injectors that work there, but as an individual, I don't know of anyone else that does more in this field, both in terms of treating patients and educating the doctors as well, than my guest today, Zack Ally. Zack, thank you very much for coming on today.
Thanks for having me. Lovely to be here. Exciting to discuss this today.
Cool. Yeah, I think there's a lot to talk about.
Sure.
For the viewers, most of our viewers in terms of the injecting world will know who you are, but there are members of the public as well. Could you give us a bit of an intro to yourself? And I know there's a lot to say, so don't be modest.
Okay.
Please show off as much as possible, because it allows people to see why your words are worth a lot of weight.
Wonderful. Okay. So my name's Zack. I've been an injector now I'm a doctor by background. I've been injecting for 13 years, predominantly in London, but I have a clinic in Dubai too. And I offer a whole host of injectable treatments, particularly dermal filler, which constitutes 95% of my practice. I also teach it around the world. I did build an organization which was quite large, spanning across 27 different cities and 14 countries around the world. I grew up to quite a large size. I managed to sell that and exit in 2022 and have since then resumed my new practice, Sculpt, which now I only do by myself, and have now ventured into large-scale conferences where I teach and educate on the Loomis method, which is an artistic technique based on facial balancing and sculpting.
Okay. And you treat patients personally, don't you?
I do,
in Sculpt.
I think twice a week in London and then once a month in Dubai as well.
Perfect. That's what I was going to ask in case anyone wants to get in touch. And we will put Zack's Instagram and everything in the description for you all as well. So that's a very large background. Now, do you think you could give a rough number as to how many patients you've treated in your lifetime? I know it's going to be in 5 figures. I've probably just tipped over 5 figures last year or year before.
I would say 5 figures. Yeah. I mean, hard to put a number on it, but
easily 5 figures.
Easily 5
figures. Yeah, I thought so. So I think across both there's a lot of experience at this table. I've probably not got as much dermal filler experience as you, but in other things within aesthetics, I'd say, yeah, definitely do. So I think the biggest topic, let's get straight into it. Fillers are in the news, not just in the UK, but in lots of different countries for, sometimes good reasons, but usually bad reasons because that's what people want to click on when it comes to clickbaity headlines and titles and things. What have you seen in terms of the negative side, which I'm sure our viewers will agree with, in the most recent past when it comes to that negative side of dermal fillers?
It's a good point to raise. And I think, it's a hot topic. It's a trending topic. All we hear about nowadays is the bad publicity of dermal fillers. Lymphatic swelling, migration, puffing, overfilling. And you hear this trend of celebrities and other people now dissolving and refilling or even getting rid of the fillers altogether. What's happening as a result of that is that manufacturers are selling less products, patients are terrified, and injectors are now jumping on the trend of moving away from dermal fillers and into regenerative work.
Yeah.
Now, while I have nothing against regenerative work and I do it myself,
Yeah.
there's always a need for structural work.
I agree.
What's typically happening is that there's too many injectors injecting now.
Yeah.
And whenever you see too many people injecting, when the economy, particularly in Europe, is poor, there's a competition for patients. When people compete, they don't say no. So typical scenario nowadays is a patient walks through the door, I want X, Y, Z, they just say okay, and often what tends to happen is no assessment, no artistic approach, they're just overfilled, puffy, irregular, and therefore you see bad work. You never see the good stuff, you always hear about the bad stuff. So I'm seeing nowadays a lot of bad work because people simply don't know what to do, how to approach a face, and are very much patient-led.
Yeah, I agree. And I think when you get to that market where it becomes a commercial market, you're going to get people at the very top, average, and very bottom. And that's the issue. And I think the biggest issue in terms of making it that way, I think, is education, both on the injector side and also the patient side. Would you agree or disagree with that?
Absolutely. I mean, education being the fundamental aspect, because now we're in the era of a specialist.
Yeah.
People are so educated now about dermal fillers that they know who does it badly, or more importantly, who does it well.
Yeah.
So if you wanted to go and search for a rhinoplasty now, you wouldn't Google a rhinoplasty. You wouldn't Google breast augmentation for a breast lift.
Yeah.
20 years ago, you probably would.
Yeah.
Now you're searching out people.
Yeah.
So you find somebody who's a specialist in female tip preservation rhinoplasty.
Yeah.
So specialists are winning.
Yeah.
The general public, these conveyor belt models, these
Yeah.
multi-threaded chains with injectors everywhere, they're suffering.
Yeah.
Whereas the experts are surviving in today's market.
Yeah.
And even further, it's hard to be a jack of all trades and master of none.
I agree.
If you do one thing and do it well,
yeah,
you'll be an expert known for it. Everything else is an add-on.
I think as a clinic, as a big, well-budgeted clinic, that's the only way you can be a jack of all trades as a clinic to offer lots of different departments. But as an individual, I think it's becoming increasingly more difficult now. And I won't say it's impossible, but I think it's extremely difficult.
Especially when it comes to brand dilution.
Yeah.
If you're going to pitch yourself somewhere to succeed, if you're offering everything and not known for anything, the cheapest person wins.
Exactly.
Whereas if you find something you're an expert at, that's your go-to. Everything else is then supplemental.
Yeah. And I think the number of experts is, unfortunately, it's not that big because you need a lot of experience, which only comes with time.
Absolutely.
And, you know, once you hit that 10-year mark, as we have, I think you just reach this level of clarity where you find you can tell within seconds if someone's a red flag.
Absolutely.
And there's mental issues there which aren't going to be fixed with dermal filler and they're going to cause problems.
It's interesting you say that because when I used to work with my last company, we used to put people in touch with employments.
Okay.
And they wouldn't really so much care about what they've trained in.
Okay.
Employees would care about how much experience somebody has. And here's why. When you're experienced in this field, you've dealt with difficult patients. You've learned how to assess them clinically, spiritually, emotionally, financially. You've essentially got a blueprint of how to deal with somebody because, you know, treating a patient is easy.
You're like a psychiatrist. Or
you're a therapist.
Yeah.
And you manage all these aspects of it, but, you know, you don't really experience till you're actually injecting a lot of patients.
Yeah.
And the more experience you get in this industry, you know straight away who's going to have a good result. More importantly, you know who not to inject. Yeah. And that's a skill you have to learn only with no textbook can teach you that.
And that, I would say that's just as important a skill as, you know, where do I put a needle, what angle, how much, etc. I think that's the easy bit, actually. It's the psychological side. You know, when I see patients now, I'm more interested in the conversation than anything else.
It's true. And I think you'll find as well with many injectors, they focus too much on the technicality.
Yeah, I agree.
But, you know, they can't really handle the patient or the demographic or everything that comes with that. Their confidence is knocked if someone's not happy. Yeah. Or if there's a bruise or a swelling. And that alone puts them off. 100%. It's a lonely world for injectors.
Yeah.
When it's lonely, you haven't got a team to balance with. You're simply the person at the point of blame.
It's just you and them in the room.
That's it.
And I've seen the people do a job which, you know, I would want a better job, but the patients are over the moon because of the interaction and how they feel. And that, you can be an average injector and get tremendous feedback and be tremendously successful if you treat the patient right.
Absolutely.
And people do realize.
You give them an experience, not just a treatment, and you won't be forgotten. And you're likable. Yeah. Actually, when you're likable, you're more forgiven.
100%. And that's the two main skills is the technical and the psychological. Yes, there's marketing and everything, but you can get other people to do that. No one's going to inject for you. No one's going to speak to the patient for you. Yeah. And they're just as important as each other.
That's what keeps them back. Keeps them high.
Exactly. And, you know, when we look at the technical side, you mentioned a few things there in terms of what problems are people seeing in the news, are the public or the viewers seeing in the news? And I agree with all of the things you said. If we just look at a few in turn, one of the things you said is puffiness. I think there's many reasons for puffiness. For example, maybe a lymphatic system problem where things can't drain. Maybe a filler choice is quite inflammatory. In your practice, I highly doubt people get the level of puffiness that a novice injector would get. Could you give the viewers and the injectors an idea of what steps the injector can take, or you recommend they should take, either physically or mentally, to understand why the puffiness is coming and what things can be done to prevent it? I appreciate there are many causes of puffiness, though.
Yeah. Puffiness or overfilling or migration, I put that under the same umbrella term. I would say, with respect to patients, as much as we need them in the interaction with the consultation, this is one industry where the customer is not always right. And by that I mean there's a heavy emphasis on assessment. So when you get to a certain level where you're injecting a lot and you have to make mistakes to get there, you learn that not every face is the same. In fact, there are 4 types of faces, 3 types of profiles, 2 types of vector, and 2 types of convexity. The minute you know that, you can look at somebody straight away and know what's going to work. If a patient comes in requesting a certain treatment and they're not suitable and the injector just goes ahead and does that, you're probably going to get puffiness. You're going to get migration. You're going to get imbalance. And actually, that's what we see. My advice to any injector to avoid that is candidate selection. That is the fundamental skill in this industry, not putting a needle in the face, selecting what somebody truly needs. It's a prescription. Somebody comes in, they're type 1, class 2, negative vector, low convexity. I know over the phone what I'm going to do. Whereas an average injector who's not knowing that is going to mess up.
And when the average injector or a novice injector, when they see someone, it takes a long time to do that. Because sometimes when it's brand new and you've got the algorithm, you've got to work through it. Both of us now, I think we can look at a patient in about 5 seconds, and without even saying it, we just know.
We know it works.
Exactly. I have to say, patients, I've seen patients think they were shortchanged because we only spent a very few number of minutes or less than a minute to look. But that is all we need when you're experienced. It doesn't take long, does it?
Not at all. I mean, like I said, it's with any craft that you've mastered, when you do so much of it, the rest of it is conveying it to the patient. We already know in our minds what's going to happen. And there are 2 ways to really classify injectors. Some are very technical. Many injectors are very safe.
I know exactly the type that you mean.
And they're more fearful about it going wrong, or, yes, the patient picks up the mirror and there's no vascular occlusion or problem. But where's the difference? Then you've got non-medical injectors, as much as I oppose them doing it, I've seen them inject better than plastic surgeons.
I completely agree. Some of them are so dedicated because they get discriminated against. Their knowledge has become fantastic.
And their skill is better. And their artistic assessment is better. But complication rates tend to be higher in non-medics because of anatomical awareness. So what you want is that perfect marriage of being clinically safe, medicalized, but visually artistic. That's the marriage that you need in this industry. That takes years to develop.
100%. And I think that artistic thing, this might be controversial. You've obviously taught a lot of people, specifically in fillers. You taught way more people than me in specifically fillers, in fact. My opinion is, when it comes to the technical side, you can teach that to people as long as they've got some level of manual dexterity. But when it comes to the artistic side, I think some people at best at least are going to really struggle because they just can't see it.
They can't.
And they have to turn it into math, which is fine. But I don't think you should look at the face necessarily always as mathematical equations. And the main reason is, I think this: if you want to figure out where to put your needle, you draw a line from here to here and here to here, and where they cross, you go in, etc. I get that. I understand. And you need to start somewhere. Nothing wrong with that whatsoever. But if you need these 4 points to figure out where they cross, how do you know those 4 in the correct place? And if they're different on each side of the face, do you follow them or do you compensate? And I think these questions need to be answered. And that's why if I'm going to be mathematical, I prefer to use fixed distance, which doesn't change as we age, which is the interpupillary distance, which gives you a rough proportion number for the face. Because you can have that a fixed distance, but the mid third be longer, lower third be shorter. And if you increase that chin length to be the same, they could have a massive face by that point. So I think that level of artistry, please tell me if you agree or disagree. I think some people are just not going to have it to the degree that's needed to be a great artistic injector.
Completely agree. Anyone can look, but not everyone can see.
Yeah. Oh, that's a great way of putting it. Yeah.
And there are people out there that's why Botox is so easy. You know, you put a needle on the face, you look at the instrument, 5 units here, 5 units there, copy paste.
Yeah.
You don't even need to look at your patient.
Yeah.
If you are too technical, if you are too numbers driven, I have to get a 120-degree nasal tip, I have to get a 90-degree bicommental. You're going to focus on a mathematical proportion rather than a customized individual. So being aware of that is important, which some injectors even aren't. But applying it customized is very different. So you're right, completely. Being aware of the thirds and proportions. My advice really to any injector is, and those that really survive in this industry, they have some element of artistry elsewhere.
Yeah.
Whether it's portrait drawing, I've been clay sculpting well before medicine.
Oh,
I do.
Yes.
That's the Loomis method. So it's all about shadows and contours and angles and proportions. And it teaches you really how to appreciate the balance of a face, but it's about harmony. Because there's a big difference between proportion and harmony. Yeah. Proportions are basically the size and the placement of your features in your face, like your nose and your chin and your eyes. You can have a big nose and recessed chin, but it's more harmony is how you put it together and balance them. Yeah. That's what I think is more important rather than just a numbers game.
Yeah. It's that concept of, are these things worth more together than the sum of their individual parts? Mm-hmm. And I think if someone's face is mostly right and one thing is slightly out, but you augment that simply to, appease an equation, but then bringing it out makes it stick out more than everything else, you've now lost that harmony.
And do you know why that happens? Because most of the training that we see today is about finding that area. Yeah. So they treat the shadow.
Numbers.
Exactly.
Yeah.
Well, they treat the shadow. They filter fill, they don't filter balance.
Yeah.
They look at that temple, there's hollows there. Patient's got a round face, but there's a hollow. They fill the temple. Yeah. Suddenly, the face is wider and the eyes are narrower.
Yeah.
So patients by default look puffier. So they're filling to fill, not to balance.
Yeah.
There's a big difference between filling to balance and filling to fill.
Yeah, 100% agree.
So people looking at just the areal location, many injectors, many beginners, many patients, in fact, are looking at areas.
Oh, yeah, I agree.
Many artistic injectors are looking at the harmony of the face, how one impacts the other.
Yeah, and I think
that's what I think the biggest aspect of differentiation of injectors is.
Yeah, I completely agree. And I think when you don't see that and you just put it there, the needle, you just put it there because you think some number is telling you to do it, I think that's one of the reasons people get puffy.
No, absolutely. And the minute you address one area of the face, something else changes.
Yeah,
exactly. You do the chin, the jaw's impacted. Yeah. Certainly, the jaw's impacted, the bigonial width, the bizygomatic was impacted. Yeah. And the profile's changed. So people start, like a domino effect, chasing that.
I describe it as a Rubik's Cube.
Okay.
You can't move one square without a load of others moving at the same time because they're all connected. And I think it's the same with the face as well. And I think, when it comes to that puffiness, obviously it's not just the volume that they put in, but I think even staging treatments sometimes can help, because if you do it little bit by little bit instead of all in one go, which I think is better for a novice injector, they might come back and you think, actually, they look all right. Thank God I didn't inject less.
Okay.
Do you think there's too much of a tendency to try and have this gung-ho attitude, I can do it all and do it all in one appointment?
It's interesting. This is where we may disagree a little bit.
Okay.
While I agree with the concept of staging treatments,
for a novice.
For a novice.
Yeah.
Okay.
Yeah.
You might sometimes be doing a patient a disservice. And I'll tell you why.
Yeah, I can see why.
They go home, you've treated the area in question, they're suddenly more aware of something else. It's called default aesthetics. You're more aware of what's missing.
Yeah.
So it's a bit like a jigsaw puzzle.
Yeah.
And the minute you don't treat the jigsaw puzzle fully, you treat individual pieces.
Yeah.
You can see the missing pieces. You put it together, you get a masterpiece. Yeah. But that means you need to really assess what's needed.
Yeah, and you got to have a good conversation
and you need
to start.
And you need to point out the fact that you're worried about the chin.
Yeah.
You treat the chin and they're recessed. Suddenly the chin shadow is worse.
Yeah.
Okay, so if you don't mention that, if that conversation happens afterwards, it becomes an excuse. If that happens before you treat them as part of the plan, it's consent.
Yeah.
The problem is that people don't point these things out. They don't want to.
Yeah.
Either through lack of awareness, they don't want to offend, or just simply they don't know.
Yeah.
So there's so many factors that come into this, and only experience really teaches you that.
Yeah, I agree. I think if you're experienced enough, I would always say nothing wrong with doing it all in one go. Obviously good technique, good infection control, blah, 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 default things. But when you first start out, I can see what you're saying. I think there is that element of reducing the risk of overfilling. However, there's that risk of, if you're a novice, well, you're probably not that good at handling the patient either. And so you probably are going to get those verbal issues that come up and say, oh, now this looks bad because you didn't know how to talk about it. So yeah, I can see both sides.
The caveat to it, there is another way around it.
Yeah.
It doesn't mean you have to treat the full face, but if somebody's going to target an area, at least target what's around the area. So I divide it, for example. If someone hasn't got budget for a full face or they simply don't know what's going to work, I probably would say divide it. Do the eye, periocular rejuvenation. Do the eye with the teardrop, the cheek, and the temple.
Yeah.
They go together nicely.
Yeah.
The nose and the chin, they balance together nicely. It doesn't mean you have to go for 6-7 mils of filler.
Yeah.
But of course, in somebody who's suitable, which trumps, suitability is the most important thing.
Yeah.
It's more important than quantity. If somebody's suitable, 7 mils can look natural.
Yeah.
Whereas if somebody's unsuitable, even 1 mil can ruin the face.
Yeah.
Suitability is far more important than quantity.
Yeah, I agree. So yeah, I think puffiness can be avoided. There may be times where you're unlucky. I think potentially there are some cases where some patients have some kind of autoimmune disorder going on, and certain fillers can flare those things up.
Yeah.
That comes down to how well you check the medical history, etc., etc. One of the other issues that you said outside of puffiness was that a lot of people are dissolving now as well.
Yes.
And I think this is giving a bad name to dermal fillers as an entity. My issue with that is dermal fillers cannot make you look unnatural. Inappropriate use of dermal fillers can make you look unnatural to the point where you end up dissolving. I'm sure you would agree with that. When it comes to dissolving, what are the most common reasons that you're seeing either in the sort of mainstream broadcast world or even in your personal clinical practice?
I would say that a bad workman blames his tools. People dissolve way too easily, often too frequently, and often they don't even need to treat the area to dissolve in the first place. When you do dissolve, obviously you can never accurately dissolve. You can never really scatter the high layers and accurately get rid of
you have
the
no
area.
control once it's in the skin.
Because you can't see. Microscopically, there's always going to be some element of filler placed that only an MRI can pick up. And of course, we know it expands. So people dissolving prematurely, I would say the best strategy really is to first of all select the right candidate. And when you see them, you don't need to do that full face each time. If I was to see somebody today do a 6 mil transformation in 18 months, I would use 3 mils and maintain it. Whereas people are dissolving and refilling or overfilling and having to dissolve to refill. It's, as you say, it's all candidate selection. The biggest issue in this industry right now is people are simply not trained in artistic proportional balancing. If that could be fixed, the world of fillers will have completely, it would have never succumbed to what it is now.
I mean, I'm going to play devil's advocate. I agree with you, but I'm going to play devil's advocate. The issue with everyone being toward the artistic side, there will always be people that will just say yes. And I think we will never be able to stop that. But I agree with your thought there. And in terms of the artistic side, is it something that you can actually learn?
You can learn it, whether or not you can apply it to something else. I mean, there's always, the clumsiness is something you can't teach. If somebody's naturally clumsy with the way they hold, I mean, I see a lot of injectors, and I can always tell by assessment the way they use their non-dominant hand. Your non-dominant hand is as important as your dominant hand. The way you hold, the way you measure, the way you pull back. Can you teach? You can teach proportion. You can teach some element of artistry, but then your ability to apply it has to take years. Some people either have it or they don't. Within seconds, we can tell this person's got it. All right. So what's a shame really is that we see a lot of artistic injectors, but they're shy. They can't market. They can't communicate. They can't sell.
Their confidence in themselves.
There's multiple aspects that go into succeeding, and artistry is only one of those. Saleability, communication, marketability, communication. All that has to come into play. But can you teach it? You can. I think you can teach it, but applying it is very different. I can teach you, for example, how to shadow and contour and sculpt. But will you be able to get it accurately or evenly? Probably not. And that's subjective. And that's what there's always be that distinguishing factor between injectors who are naturally more artistic and detail focused and those that aren't.
I think that's what makes the difference between people that have a long-lasting career and those that give up at some point, or people that become truly prolific and great injectors, rather than run-of-the-mill, your bog standard average clinic as well.
And it all comes down to detail. When detail appreciation in any industry distinguishes good from great. And to understand detail and proportion, you need to really appreciate where things are lacking. It's like filling in the dots, and that's what drawing teaches you.
100%. I was never really good at drawing though. But in terms of the dissolving, there are people that talk about horror stories. I dissolved it and I looked terrible afterwards, etc. I have my opinions on that. I think there's actually a scientific process that is going on, which is a whole big discussion in and of itself. I'm just curious from your personal practice, when you do dissolve, I would hazard a guess that when you're dissolving at something that you've done, you don't have a horror story. You just have someone that gets to where they want to go. When people do dissolve and, it doesn't quite go well, I've got my thoughts on this. I've seen the scientific basis behind this, but just curious in terms of your thoughts. Why do you think people are having that happen? Do you have any thoughts in personal practice? Do you have any thoughts from the scientific perspective? Anything?
The first thing to mention is the molecular weight of dissolving hyaluronidase is very low.
Yeah.
So where you place it is really going to impact how it's going to look in 2 weeks.
Yeah.
You can over-concentrate, under-concentrate, you can put it superficial, you can put it deep, you can put it with a needle or a cannula.
Yeah. Even dilution.
Or the dilution impacts it. So I think dissolving really itself is a skill, and dissolving should really be planned out. You know, you should try all other avenues before you get to a stage of dissolving, including warm saline, or molding it down. If you get to a point of dissolving and over dissolving, you know, we've learned that, you know, you can naturally take away your own hyaluronic acids, especially in delicate areas like the eye.
Yeah.
So you can dissolve everything and suddenly the skin's worse.
Yeah.
So rather than refilling, you have to address the skin. So laser treatments, fractional, you know, skin boosting, Sunacos, all these other things that actually work on other aspects. So you sometimes create a problem for yourself when you dissolve, and it becomes harder to get that finish at the end.
Yeah, I mean, I think when it comes to the dissolving of the endogenous hyaluronic acid, I agree with you. Yeah, it's going to have an effect, but also that's turned over anyway. So my view on that is, I agree, but I don't think it's as bad as the other stuff in terms of the overall aspect. I mean, there's a paper by Caroline Wilder, Daniel Ezra, back end of 2024, I think, and they looked at what happens in these things. And I think in the cases where you dissolve and maybe things look caved in, it's not that the dissolving did that. The filler did that. And the dissolving just shows it up because you can see it now. And they did not just ultrasound, but MRIs, 3D MRIs, where you can actually see that actually happening. So I think the dissolving, 100% agree, it's a skill in of itself. And the instrument you use, the amount, the dilution, the massage even potentially, things like that, they all play a role. And my view is the dissolving itself may be responsible for some level of minor damage, but it's going to show up the damage that is being hidden by the filler in the first place.
Right. Okay. Makes sense.
But there's not enough evidence to show, because I mean, that one paper, as brilliant as it is, there's not many more like it. And I think we need more people to think about it and do experiments to show that. And
you're right. Most of the views around dissolving are anecdotal.
Yeah.
It's based on opinion and experience.
Exactly.
Whereas we haven't got these, RPs that are showing what happens with it over the years.
Yeah.
We are seeing MRI studies showing that filler can retain.
Yeah.
We're not really assessing and examining the hyalase effect.
Yeah.
So, I mean, we don't know.
Yeah. And they do call it the hyalase effect or the hyaluronidase effect. And it's actually a very, very interesting reading. And I think it's actually changed my practice quite a bit as well. In terms of the reactions to fillers, you know, people do talk about, I got these lumps, or it went hard, or something like that. What's your experience in that in terms of most common reasons that you see that happening?
A very good question. Very under-educated on as well.
Yeah.
So often, you know, besides the average swelling and bruising, which can vary between patients, I think we need to address granulomas. And that's a thing that's often being brought up. Granulomas reactions have been linked to certain types of hyaluronic acids, but more importantly, they've been linked to certain types of patient, and it comes back to candidate selection.
Yeah.
If somebody's got unstable autoimmune disease, a common scenario we've been seeing is suddenly 3-4 months later, they're coming up with loculated hard nodules.
Yeah.
And people are then going to town, dissolving. And you can't because it's a body reaction.
Yeah.
So what you really need is like intralesional steroid, Kenlock, to dissolve down multiple times before your hyalase.
Yeah.
Because that's another problem being caused now. People dissolving the wrong type of patient with poor diagnosis and poor assessment.
Yeah.
So unstable autoimmune disease is naturally a red flag
Yeah.
granulomatous filler reaction. Something we often don't talk about enough.
I think any patient with any level of autoimmune disorder, even I would say, in my experience, eczema, psoriasis as well, they should. You need to think twice. You need to think carefully. If it's pretty minor and nothing's going on, fine, but you need to keep it in the back of your head, and you need to have that conversation. And I think autoimmune patient or patients with autoimmune disorders, you have to be very careful with your filler selection as well. If you're using a filler that has, you know, at least historically, anecdotally, maybe even scientific literature-wise, a higher than average adverse event rate or complication rate, I think it's worth you forking out a little bit more potentially for a slightly different filler, which doesn't have that.
But unfortunately, this data is underreported.
Yeah.
So we haven't gotten...
So no one knows.
Yeah, it's all unfound, and we're discovering... It's like telangiectasia and hypervascularity that we're seeing a lot in patients. People often blame the filler.
Yeah.
When in fact, anybody with a Fitzpatrick type 1 over the age of 50, thin skin is prone to that with too much expansion.
Yeah.
People are blaming filler. Again, it's all anecdotal. So we don't have enough data to back
Yeah. This is going to sound a little bit sad, but I don't think we'll ever have enough data.
It's always going to be underreported.
Yeah.
Egocentrically, people will not report the side effects.
Exactly.
So we can't study it.
So I think that's one of the major reasons. I think the other major reason is the fact that when you try and fund a study, you got, an ethics board or a university or a hospital, and they've got, a budget for the year. This group has come along and said, we want to study what happens in cystic fibrosis patients when this happens, and we can help a lot of people. They say, fine. And then this group comes over here and said, we want to see what happens when we improve people's wrinkles and are they satisfied? The money's going to go here.
Absolutely.
And so there's no funding either.
Yeah.
And the public will always say, like as if there's some, scientific genius, I want to see where the evidence is. You're not going to get evidence. If you're asking for evidence in cosmetic things,
good luck.
You have no idea what you're talking about.
The best evidence right now is on TikTok.
Yeah, exactly. I mean,
nothing there. It's true. And you're right. I mean, even big pharma, will companies attach their brand to that? It's going to be biased. KOLs will 100%. Pick a certain product over another one.
Yeah,
exactly. It's all personal gain.
And you just got to accept that. My opinion is the best way to deal with that is education. If you are educated, if you can pick up any scientific paper, and I did this in my online school recently, actually, we looked at a product called Profiler Structura, and I tore that paper to shreds and said, there's no control here whatsoever. And this is a load of crap. And the injectors who I was teaching, they didn't even realize how to think when they were reading the paper. And that's the problem. You can have bias in these things. That's not a problem. But the injector should be able to spot the bias, account for it, and still work out whether it's good or not. Because I don't think bias is the issue in a paper. It's the methodology and the validity and credibility of the conclusion. And you can be biased because you're employed, and sometimes you have to be, because who else is going to fund your own product study? It has to be you. But if they choose a methodology which is reliant on their opinion, that's not valid. But if they choose a methodology which is completely objective, doesn't take anyone's opinion into account, and it can be repeated if I did it or you did it, then that's fine. The funding may have come from the company, but the experiment was valid. And I think, that way of thinking is not taught, unfortunately. And I think that's the issue.
Yeah.
And what were some of the other things? We talked about puffiness, we talked about dissolving, granulomas, lumps. What are the other sort of major issues that you see?
I mean, there's issues and there's complications. So if we talk about issues, the swelling and lumps and bumps, they're given. I mean,
you got a needle going through the skin. Right? You're going to get something.
And some lumps are, palpable lumps versus visible lumps. There's a difference. Sometimes we create them with bolus technique. If we talk about serious complications, things that people often don't know, blindness, for example. Now, again, this is very underreported. I feel like very few injectors want to talk about a situation of a VO or a blindness or necrosis case.
Agree.
But again, it's something not taught about. There's been, 2 or 3 major cases around the world.
And one on stage in Korea.
And one was reversed in Australia. So I don't know if you know that one.
No.
But one on stage in Korea. So the risk of blindness, again, statistically, we know is higher in some areas, right? It's why there's lots of fear-mongering around the glabella and the forehead and the nose.
Which is astonishing, because when fillers came out, people were just shoving needles in here like nobody. How were there not no more blindness cases?
Until something happened. There's parts of the US, for example, where, from a legal perspective, many medical directors don't want their nurses doing noses. There's always a safe way to do something. You're at risk of causing a VO anywhere. An occlusion can happen in the lip. It can happen in the jaw.
Even to the best of us.
To the best of us. I guess what's important to talk about here is how do we minimize that? And the way to minimize that is to take away the high-risk patient. Anybody with surgery. Jaw implants, a surgical lip lift and invert the labial artery and risk of having occlusion. Multiple rhinoplasties create scar tissue and vascular migration. Deep plane facelift, vertismoplasties, they all push your vessels everywhere. So risk is higher. We all know that for a fact. In surgical patients. One way to mitigate that risk is to avoid a surgical patient. The second thing is, when you talk about blindness, because that question comes up in my clinic all the time, especially around the tear trough, or when I do forehead fillers or noses, there's always a safe way to do something. Okay. Anatomically, being aware is the start. But if you do cause a flickering vision, what do? I feel like a few injectors know what to do in situations like that, apart from panic.
And retrobulbar injections, they're not taught.
Retrobulbar hyalays, apart from a cadaveric injection, most injectors probably won't know what they're doing. But most oculoplastic surgeons or ophthalmic surgeons do retrobulbar blocks all the time. So knowing who's in your remit to contact if something happens, there are things you can do as a practitioner. So if someone's vision is flickering after a procedure, objectively assess it first, lay the patient down in a supine position. You want to make sure you get rid of as much CO2 as possible. So CO2 rebreathing, the glaucoma treatment.
Like a paper bag, I think.
Paper bag rebreathing, ocular massage, treat it like a glaucoma case. That's called the Lazeri protocol. And within a few hours, or at least a few minutes to hours, you want to be contacting ophthalmics because you need to have access to retrobulbar hyalase.
Yeah.
There's studies now, and rather than doing retrobulbar hyalase, get an ultrasound scan and find the supratrochlear
I'll go through
and
that.
flush that. But that's hard to do.
Yeah.
Practice, unless you've got a nice butterfly cannula.
Yeah.
Hard to get that in there.
Most people don't even have the ultrasound now.
That's right.
Yeah.
It's the same with hyperbarics. People don't have access to these.
Yeah.
So, there's always ways and means of mitigating risk.
Yeah.
But my point being made here is that you can get a vascular occlusional complication anywhere if you're not aware of the anatomy.
Yeah. And I think when you have a surgical patient, I completely agree. It's not as simple as just saying, oh, there's probably scar tissue anyway, you'll be fine. You still need the ultrasound, but even then you can't guarantee because the ultrasound will not show you everything, I think. Yeah. And with a surgical patient, I think my thinking is if you're going to treat them, the only time I would feel okay is if I was using a cannula and I was able to put the cannula in and move it from side to side, which I wouldn't be able to do if I was in a blood vessel. If I was using a needle, yeah, it's got to be under ultrasound live. And then I would keep the patient there and monitor, assuming it was a high risk area at that time. Other than that, I don't think there's any other way to treat those kind of patients.
No, and even there's a big push towards ultrasound now, especially in the US, where there's a lot. You have to remember as well, having an ultrasound probe in your left hand and a needle in your right doesn't guarantee your accuracy.
No.
It can be helpful and supportive. Don't get me wrong, it's very effective for just diagnosis. But practical treatment using it's
not easy.
Even pressing the ultrasound on the vessel can shift its position. Yeah. So little things like that come into play.
Completely agree. And I think that what makes that harder is the start of the appointment. Because at the start, your syringe is full. So your plunger is further away. And I've seen, when I've tried to teach it to people, especially, I'm not going to sound sexist, but female injectors with smaller hands, and they struggle to hold that big thing, and they've got this, it's very difficult to stabilize that needle, that syringe, when it's off. Whereas if you're using something like an insulin syringe and you can rest like this, it's much, much easier.
Yeah, dexterity is definitely impacted.
100%. And it's much, much harder when you've got a big, heavy instrument at that point.
In terms of those instruments, are not ergonomically crafted. They're quite bulky.
Yeah.
Clarius, they're quite big.
Yeah.
And again, it's getting used to holding it on a patient while injecting. It's multiple things being done.
Yeah, really not easy. And it's a big technical skill. Let's talk about ultrasound. I mean, do you use ultrasound personally?
To be honest, I don't. Okay. I have only for vascular mapping and diagnosis, but in practice, no, I don't. No.
Okay.
I'm so used to knowing where I'm putting the needle in, my candidate. I'm aware of structure.
Yeah.
And I know what to spot.
Okay, perfect.
So I'm quite confident to not have to use that.
Yeah.
I have tried to use it.
Yeah.
I don't think it's added value to my artistic technique or placement.
Okay, I mean, the artistic side, I completely agree. It's never going to replace that.
I think it ruins it, actually.
Yeah.
Because I use my left hand to tort quite a lot. And I really position all with my left hand. A probe suddenly takes that away.
Yeah, definitely agree. In terms of the technical aspect, is it interesting you say that you don't use it? I do have one. I use the Vin OP, a little bit lighter than the Clarius, still great image quality. But I've got to say, I agree. I don't use it all the time. It doesn't necessarily guarantee safety. When a patient comes to me and says, do I still have any filler left? I'll get it on. And sometimes I can actually see it and say, yeah, it's here, it's moved. So they probably didn't dissolve, put the needle in the right place. And I was like, okay, it's over here. And if I push here, it goes that way. If I push there, it goes this way. So when I put my needle in to dissolve, I'll do it the same way, push and then go this way if I need to. I think other than that, it's not that useful personally. Would you agree?
I do. And let's be honest, if they do have some filler left microscopically, does that matter?
Yeah.
If you can't see it?
Yeah.
Probably not.
Yeah.
A lot of people walk around incidentally with all sorts of lumps and bumps in the body, cause no harm whatsoever. We are simply using it to diagnose, in some case, unnecessarily.
Yeah.
Do I use it for vascular mapping or sometimes being aware of the vascularity and maybe complications? Yeah, it will be useful there.
Yeah.
In terms of day-to-day practice, I'd say 95% of the time I probably wouldn't.
Yeah, I think when a patient comes to me, they've had filler elsewhere, that's probably the most common reason I will pick it up, just so I can see where it is, what's happened, etc., etc. And I've got to say, one thing that has really stood out to me in using ultrasound, I don't know if you found this, or maybe in the colleagues that you've spoken to who will use it. When I see someone, and I made a video about this on my channel a while ago, someone came to me having had 2 different brands of filler. One of them was Revanesse, I think, and the other one was, I think it might have been Juvederm or Revelax, one of the 2 that I really don't like. But even on ultrasound, I could see the difference. I could see the way the Revanesse had just stayed where I'd put it. And the Juvederm, which had come from elsewhere, it had just spread, and they could see the layer around it. It was like the body was creating that capsule to try and separate itself as well. And even the density within the filler, it was not even, whereas the Rev and S was the same color all the way throughout. Have you ever found anything like that?
I haven't actually, no. I have seen that with, I've heard of it with Radiesse and hybrid fillers.
Yeah, I can
really
imagine that,
see the product.
Yeah.
Not in my experience, I probably haven't.
Okay, interesting. So if someone was new to injecting, or even to a patient, and they were going to see an injector, are you saying, and I think you are, and I'd probably agree with you, that they should not reject an injector simply because they don't have ultrasound?
No, they shouldn't reject it based on ultrasound.
I agree.
No,
I agree.
I think that's not a fundamental aspect in selecting your injector.
Yeah.
I think one of the best way any new injector, in fact, any patient, let's talk about patients here.
Yeah, sure. How should the patient choose an injector?
And this goes for surgery too.
Yeah.
If you're a surgeon,
a
plastic surgeon that does everything from top to toe,
yeah,
front to side, injectable, you're not going to be an expert.
Yeah.
We're seeing surgeons now super specialize in deep plane facelifts or breast augmentation. They pick one area, master. They've seen everything, every possible complication, and you've had to have messed up a few times to relearn how to do things. Otherwise, if you're not getting complications or issues, you're not treating enough people.
Yeah.
That's a fact.
Yeah.
So I think if a patient's going to select an injector, obviously apart from being medical and qualified and clean and hygienic and knowledgeable, and trained in complications, which I think are baseline, they should select somebody who does that all the time.
Yeah.
If they're doing it every now and then or on the weekend, or they do multiple treatments and this is like an add-on, they're going to be really appreciative or aware of what that person can do and how they can look after you.
Sure. I think there's one exception to that, which is people I think can do it now and again if they've come from a career where they were doing so many. And they're now slowing down because they're close to retiring or something like that, and they don't need that much work. But if but
that's a natural progression when somebody's been doing it for so long.
Exactly.
I mean, I've been injecting for 13 years. I used to inject 7 days a week.
Yeah.
I injected 7 days a week to inject 2 days a week.
Yeah. Yeah, that's a good way of putting it.
And I've culminated my practice where I know who's going to, I mean, even my marketing, a lot of it has been done on social media.
Yeah.
People often looking at my before and afters and looking at the kind of category of patient I see.
Yeah.
So I talk about the face shapes and the profile. They come in knowing what face shape, what profile, what vector, that they know what they need.
Yeah.
So I'm simply confirming on the day.
Yeah.
Back in the day when this didn't exist, we'll be sitting opposite each other. I'm going to have to sell to them.
Yeah.
And educate. That's hard.
What a change.
And it's actually helped us. So social media has the benefit of really educating your patient to get that right treatment.
Yeah.
So you don't need to be injecting 7 days a week, but with experience, we typically taper down, don't we?
Yeah. And in fact, it's interesting to see that the same thing happens to me. I've got patients that might come to me with a thyroid issue, an autoimmune issue, or eczema, or they, just skin they don't like, but they've watched so much of my content, they'll come educated and they'll say, I'm thinking this, this, and this. And I simply say yes, or the slight tweak, or say no because of this. And then it's a very short conversation and it makes it so much easier, and there's no selling.
The educator era the patients are in today, both good and bad, has actually helped us, because
I agree.
Even if they're wrong, it gives us a chance to then challenge it.
Yeah.
Back in the day, people were clueless. They had no idea.
Yeah.
And now people are so aware, which is why we're in a specialist era.
Yeah.
So being a specialist today serves the mass public.
Yeah. And I think even if a patient thinks they know everything they need to know in this context, and they try and challenge you, I don't mind that, because it shows me that they care and they have self-respect. But what I do mind is when I show them, the counter argument, which is valid, and they disagree as someone that has no experience in that whatsoever. Like, well, why did you come to me then? What's the point? Now nowadays, I don't remember.
That's part of the screening process. We mentioned the screening process. So the more you inject, the fewer patients you treat. You say no quicker. When you start out, I mean, when I started out 13 years ago, I would treat anyone. I want to just keep them happy.
Same. I'm not gonna lie, I was the same.
And then suddenly you realize not everyone's happy. And then you realize one of two journeys could happen.
Yeah.
I could either quit and be put off and my confidence could be hit.
Yeah.
Or I could learn, why is this person not happy and why is that person happy?
Yeah.
Why did the work there and not there? Because that person's suitable, that person is not, because they have that anatomy.
Yeah.
And like I said, no textbook can teach you that. Only experience and time can.
Yeah. Listen to the right people.
Yeah.
And that's it. And I've got to say, actually, this might be controversial. I don't think a conference will teach that either, because all conferences now, any talk that you go to, they're all the same talks anyway, and they're all sponsored.
Yeah.
No one's allowed to actually speak their mind.
Their mind, that's right.
Yeah.
Do you know the highest complication rates happen after conferences?
Really?
People often watch it and go and try.
I think, I can do it, and then they go and try it. Yeah. Bloody hell. I mean, I'll give you an example. I used to speak at CCR, which is a big conference here in London, for those that don't know.
Yeah.
In fact, it's just over there through that window, Excel Centre in London. And I used to always do a talk, and it was usually with a company educating in something. And one year I thought, this is a couple of years ago, I thought, why don't I send my own topics in to the organizers and see if I can just put an education talk, not to sell anything, just for education. And I put some things in there, which I knew would reduce sales of certain products. Didn't even get a response. But when it's a sponsored talk with the company, yeah, please go ahead, say what you want, blah, blah, blah. Like, this is ridiculous. You're never going to learn in a conference nowadays.
Yeah.
I think it's bullshit, frankly.
Completely agree with you. Do you know what? It's interesting because I've created this facial sculpting masterclass, which is based on my Loomis method approach to play, right? It's attracting sponsors. I'm not filler biased, I'll be honest. You can put the most expensive product in the worst hands and get a crap result.
Completely agree.
And you can get something less well known in amazing hands and get an amazing result. The bad work on blames is tools. The skill is not the product, it's always the injector behind it. And I think, you know, with this concept I've created, the Loomis method, it's suddenly attracting all these global sponsors where they want in. And I'm not going to be biased to their product, I'm going to be biased to my approach. If they want to be part of it, that's fine. I'm not going to change the way I teach things. That's what I think is mandatory today. That's what's needed.
And that's rare. You know, I notoriously, people have said, Abs, why are you not, you know, a KOL for this or that or that? And I have to fully believe in it, which is why there's only one company that I have agreed to be a KOL for, which is the Sunakos product. And back in the day, I was the KOL for Dermal as well, the LED. They're not doing as much now, but I'm still with them if they need me for anything. That's basically it. I've had offers from filler companies, from device companies, from toxin company last year as well. But I don't accept it from anyone. And you see these people stand on stage and they list their conflict of interests, like as if it's a badge of honor, or I speak for 13 different companies. And I just I think, so you just speak for anyone then? Like, so you're saying this is the best injectable, and then the following week they'll say this is the best injectable. And I'm like, well, they're competitive products. Like, what the hell are you doing? And I think that's
paychecks. That's right.
Exactly.
You're paid to say what they say. I mean, look, my last company, we were sponsored by a couple of companies, and I was a KOL at times. But you're not allowed to teach. You had to then be, you know, have it into what they teach. Their way, their research, their label. The reason, you know, my courses are, I'd say, popular in the UK and around the world, because we get lots of off-label treatments. People come from all over the world where it's label there and off-label here. They can see another side to things. Where it's not based on, you know, you can do it for it because the research says you can't. Do you understand? There's ways and means of doing everything. It's just
100%
through experience and anatomy and the way you educate it.
And I think actually that's, if I'm being, this is going to sound a little bit sad, possibly a little bit funny, depending on the person, but I don't think I will ever be able to speak freely at a conference. I have spoken about other products so many times on social media, in public, to say, this is terrible, this is terrible, this is terrible. And I'll back it up. I'll say, for this scientific reason, this one and this one and this one. Let me tell you, I've never been sued. None of these companies have ever come after me because I know my shit. I know that is scientifically valid. So for example, I did a call on my online school where I teach. We ripped apart this product recently. And I've actually done that in public as well, in front of the company, because I ripped apart their scientific paper. Nothing happened. And I think that is sad. So when I teach skin, devices, lasers, injectables, skincare, or whatever, i.e. the non-filler, non-toxin side, and how to rejuvenate the skin, the feedback I always get is no one's ever talked about that before. No one's ever taught that before. And the reason is, if you understood that all, you would only use Sunakos. And I can back it up. And that's why I said to you off camera, no one's ever wanted to debate me, but there's always an open door invite, and you wouldn't buy any other product. And so for that reason, I'll never get picked to speak freely at a conference. And I don't think you will, in the way that you probably would want to.
And do you know what? It's interesting you say that, because it's true. And I think when you've really understood something, really understood it. And I mean, not just what you're told to understand, when you've taken the time to kind of even mess up a little bit or learn yourself through trial and error. When you've read it, you can't challenge it. Well, you can try to challenge it, but you know, your work and your experience talks for itself.
100%.
You know, a lot of the time, when people talk about how fillers are bad, and we see this everywhere because of celebrity trends, it's bad in the wrong hands.
I agree.
I'm never going to stop doing it. And people, like I said to you earlier, people like you and me, we're not going to really struggle in business because we've mastered to the point where we know what's going to work and what doesn't work. We don't follow these silly trends of, well, let's move away from this and let's just do that. No, there's always a room, both pre and post-surgical, for dermal fillers.
100%.
Before a facelift or as opposed to a rhinoplasty.
And people got to understand as well, if you see X number of stories which are negative about it on the press, you're seeing negative stories because that's what sells. People like the dramas. I want to click on that.
It does.
Well, I will hazard a guess, there's at least as many great stories out there, but you'll never know. I mean, I've got patients, I'm thinking of one right now, actually. She is on TV. I won't say her name because out of privacy, but I've injected her over the years, and she's on TV and she says she's not had anything done. Now I know she has, but she can get away with it because it generally looks like she's had nothing done, and you'll never know. If it's good work, you'll never know it's been done.
Best injectable is undetectable.
100%. Oh, that's a good phrase. I like that. Yeah, completely agree.
Yeah, you're right. I mean, undetectable facial balancing through selecting what's needed, back to proportions.
And you'll never know. So yeah, let's move on to a little bit about, from the issues of dermal filler to the education, because I think education through a certain lens is an issue as well, in the sense that there's a lack of it. When you set up the company that you've started a while ago in terms of creating injectable education, how to carry out fillers and how to carry out toxins, obviously that became huge. And I would say that's probably the biggest training academy anyone has ever made in the world. And I've got to say, since you left, obviously it's gone down the toilet, which I find quite funny. And I'm sure you probably off camera do as well. But when you were starting that, you saw a tremendous number of novices who have never come to inject before. Some of you have come on to become great injectors. Some of whom have possibly just had a really awful time, maybe because they didn't like it, fair enough, or maybe they just did really badly in their injecting. I'd like your opinion on what kind of similarities and differences cause some to go this way and some to go this way.
Okay. We never got to really audit this, but you can almost keep tabs. You can tell again within 5 to 10 minutes of somebody being in front of you whether they're going to make it or not.
I just how they hold it even. You can tell.
Even beyond the skill, some people that are really dead serious, I mean, you have to understand, we can give you the recipe, but you've got to cook the meal, right? So people, I mean, those that I know are going to do well have come to the course, they've got a website, they've got a business name, they've registered on company's house, they've got a premises, they've got a brand, they've got their scrubs, they're ready to go. They've even tried.
Scrubs is a big thing, isn't it? With the logo and the signature,
Whereas the ones that are not going to succeed, usually it's I'll wing it. They haven't even read the manual. They turn up expect to learn everything there and then. They blame the system for not progressing. It's a cutthroat industry. It's competitive. We understand it's a high lucrative industry as well. So those that really do want, that do succeed are already succeeding. They've already made it happen. They're here for the certificate and the training. And even if they haven't fully learn what they need to on the day, they'll come back and do more. You've got to spend money to make money. And those guys that really are serious and dead serious about it know that and are willing to. It's those that are frugal. They don't want to spend the effort. They haven't given it the time. They won't even go and treat somebody afterwards. Whereas these guys that are serious have got models lined up on the next day. Do you understand? Taking the steps necessary to get there. And actually, they don't mind the grind and the hustle. They'll work every hour of the day. They'll even work for somebody, build up experience. It's like when you hire somebody. When I used to hire people working for me, I used to get beginners and I used to get 2 types of beginners. And I understand that everyone's got to start from somewhere. The way you sell yourself and pitch yourself determines how you're going to progress, right? So if you've just done a course and you go to a clinic and say, look, I've just done a course. First have a course, I'm a bit nervous. Will you hire me? Versus I've done a course over the weekend. I've learned X, Y, Z. Here's my background. I'm a medical doctor. I've learned the technique. I've injected some patients at home. I'm willing to learn and develop. And I'm really excited. Who are you going to hire?
Obviously.
It's the way you pitch it, right? And that's the same with the progression of their business. Those that come with a strong business acumen and a strategy or plan, they're going to make it. Sometimes even if they don't have a skill, they just have the knowledge or the know-how.
And the will.
And the will too.
Completely agree. I think 2 people, the way I always phrase this is, if you imagine a story in your head where you've got the school playground, the same kid in both versions of this, he gets bullied and he grows up. This bullied kid can become a bully to take it out on other people, or it can maybe become a social worker because he knows what it feels like and helps others. It's not what happens to you. It's how you deal with it afterwards. And if you go and just do a course and you've got minimal experience, it says nothing about your future. It's still wide open. And I think the mistake that some people do make, and I'll be interested to hear your opinion on this, is some people never leave that mindset of being too scared and they cover up for it with just doing courses all the time. And you can tell they're just constantly coming back, but they're never applying anything. Do you see that?
I do. You also got the counter opposite of that, where people fake it to make it, where they think they know everything. And actually you learn.
That's very true.
So you got two polarized versions of that.
Yeah.
Yeah, you get those that will always want to be under the umbrella of somebody else.
Yeah.
But their level of risk is very low.
Yeah.
They're very risk averse and they're trend followers.
Yeah.
In fact, there are 4 types of injectors.
Okay, let's hear it.
Type 1 is that trend of I'd say that the quiet pushover type delegate who's following trends, always needs to be under the umbrella.
Yeah.
If they say that doesn't work, I'm not going to do it. Filler they're bad, I'm going to move to regenerative.
Yeah.
They're going to be trend followers. They often burn out. They're stressed. They have little business acumen.
Yeah.
You get those that I'd say rock stars. I've had a fair few of those over the years.
Yeah.
They come in with very high egos. You often see them at many conferences, and you see more of them than their work.
Yeah.
You get you get academic injectors, and all you ever see on their page is vessels, or retained ligaments, or arteries.
Yeah.
Never work. You know, the science says I can't do a nose, I won't touch it. They're very academically led. Yes, they'll get safety as an element and a pushback.
Yeah.
Often they use that as a way to put down non-medics.
Yeah.
Does that bring you business? Does that make you money? No. You can publish 100 papers on non-surgical rhinoplasty, but if your work is crap, people aren't coming to see you.
Yeah.
And then you've got type 4, which I'd say they're designed for this industry.
Okay.
They're truly artistic. They do something outside of medicine or aesthetics, which is purely artistic. They get it.
Yeah.
They're not clumsy. They know how to look at face. You can sometimes look at somebody straight away and be quite impressed with the way they held that and injected and the technique and the dexterity.
And it's so obvious sometimes.
It's very obvious.
Because when you've got a group of people and one sticks out.
But sometimes it's a shame when they're silent and they're quiet and they're nervous.
Yeah.
Or they can't talk or they can't market, because you need that recipe. In fact, you need 5 things to really succeed.
Yeah.
Skill is one of them. And I think you really have to actually have that skill and be good at it.
Yeah.
Marketability, a presence.
Yeah.
I think having a presence and being communicative with your patients and being not afraid to have your opinion and follow trends. You need to have the ability to, I think the looks matter. I do think your brand and your image does matter.
Yeah, you can't be talking about how to live healthy and be massively obese.
You would never go to a dentist with bad teeth. You would never visit an obese bariatric surgeon.
Yeah.
Right? So you got to practice what you preach and put it out there. And I feel like you got to be online.
Yeah.
There's no point having a company and a website if it's just quiet. We're not living we're living in a social media generation.
Yeah.
Pamphlets and radio advertising doesn't work anymore. You got to be social. You got to be out there. You got to engage. You got to network.
Yeah.
And I feel like a lot of injectors might struggle with most of those. They only stick with one. Being medical alone is not going to help you grow a business.
Yeah.
Being very well marketed, but with poor work, you're not going to survive.
Yeah.
You need to have all those recipes to make it your thing. You make it your forte.
Do you think it's possible to change which type you are? You've got someone who's very timid. Have you seen timid people actually become very confident and great injectors?
I have, yes.
And what does that take?
Sometimes it's not even the skill. Sometimes it's collaborations.
Okay.
Sometimes just being around the right people suddenly makes you feel important.
I see.
I think, essentially, the more you treat people, the more you're going to start to develop a confidence.
Yeah.
Some people don't like talking in front of camera. Suddenly they do it.
Yeah.
And they find it's like talking to their friend.
Yeah.
Right? It's your mindset.
Yeah.
I do think it's adaptable. I think it's changeable.
Okay.
You have to be flexible to do it.
Okay. So it's a mindset thing.
It's a mindset. If you're fixing your ways, you think you know everything, you don't go on training anymore, you're stuck in your old patterns, you're never going to progress.
Yeah.
Time moves, time changes. And you've got to go move with it.
So from a patient perspective, let's pretend a patient is going to a clinic and there's 2 people working at this clinic, hypothetically. One of them is the kind that turned up to their course, having read up on a load of anatomy, they brought their notes with them to mark it off, they're making notes as you're talking, blah, blah, blah. And the other one didn't even read the pre-course reading, has no idea. What can a patient do to try and figure out which one their injector is? And I appreciate it's not an easy question to answer depending on where you are.
I think, and I said this to a patient of mine yesterday who happens to be a medic, you can tell within the first 5 minutes of talking to somebody whether somebody's bullshitting you.
Okay.
Just through the questions they ask. So something I would do as a patient, I often put myself in the hands of a patient.
Yeah.
And I try to imagine if I was a patient visiting a physician, what would I want to know? Little questions about awareness, like, okay, do you think I'm suitable for this and why not? Tell me why I'm not suitable for this, not just, okay, whatever you want.
Yeah.
People build trust in somebody when knowledge is there. Right?
Yeah.
And you can demonstrate value simply through knowledge.
Yeah.
If somebody comes to see me and is purely led by me, often they've done their research, the power's in my hands. But some patients aren't like that. They're very much, they ask questions. They want to know about the products. They want to know about your experience. And I feel like we've moved beyond now just credentials and,
I cannot agree more. I cannot agree more.
Yeah. That's a common one. You probably see in your...
Jesus. Honest, I could go on about that. You've hit the nail on the head.
Yeah, I think
it does mean nothing.
People, I mean, look, you can have I've seen plastic surgeons with 100 letters after the name.
Yeah.
Some of the worst injectors I've tried.
Yeah.
Just because you're a surgeon, it does not make you an artistic.
Yeah.
Even surgery. Some surgeons are not artistic surgeons.
No.
You look at the result and you think they went through a deep plane facelift and paid 20 grand.
Yeah.
It's a difference.
And surgeons, let's be frank, yeah. Surgeons' patients are asleep. They can't say ow.
Yeah.
They're not used to people awake. And they use a scalpel.
Yeah.
Not a fine precision instrument like a needle. I mean, a scalpel is a precision instrument, but it's not like a needle. With a scalpel, you could, go a bit too far and just, if you get a wound, if you get a vessel, you can cauterize it, whatever. With the needle, if you go too far when you inject, you could go into a vessel and then, cause blindness.
But they're a surgeon, so it's okay.
Exactly. God, I'm so glad you said that. Yeah.
But look, as a doctor myself, and I've done surgical training in my medical training, it doesn't guarantee you being artistic. It really doesn't.
No.
But back to the topic earlier, like I think what a patient can do to their injector, honesty. An honest injector doesn't say yes to everything.
Yeah.
I had a patient yesterday who they came in for teardrop filler.
Okay.
Right. And she wasn't suitable. So she wanted to assess what I know about teardrop filler. I could have said yes and do it. I could have just said no.
Yeah.
What I did really was give her the option and explain why she's not suitable. I think if you can explain why something,
they appreciate that.
They appreciate it.
Yeah.
So I looked at the skin quality.
Yeah.
Is there pigmentation? Is there hollowing? Is there actual herniation? Which surgery is the best option?
Yeah.
Do we treat this with laser? Is microneedling an option?
Yeah.
Volume replacement, fat transfer?
Yeah.
If you're looking for a permanent fix?
Yeah.
Or regenerative work?
Yeah.
If you can give this grounded, holistic opinion, patients know you know what you're talking about.
Yeah.
Many injectors simply say yes or no, or don't know enough.
Yeah.
They don't know exactly why somebody with a class 2 recession isn't suitable for lips, because their patient's looking that way and so are they.
Yeah.
No one's really looking that way.
No, you can't see yourself that way.
You can't. And then suddenly the chin's impacted.
Yeah.
And we tend to see happen these days where patients put all the pressure on the injector.
Yeah.
I want to have my lips done. The injector suddenly says yes.
Yeah.
They go home and they don't like it because they feel like they're shelving.
Yeah.
A lot of patients don't like to admit that they're wrong. So they'll say, all 20 people on the bus, all my friends say I look worse.
Yeah.
Well, in fact, they weren't suitable.
Yeah.
And they can't admit that they didn't see that too.
Yeah.
But injectors this is why I say the customer is not always right.
Yeah.
You come to me with the class 2 profile, I'm not doing your lips, I'm doing your lower third.
Yeah.
That's how you harmonize it.
Yeah.
So that's why I think you can marry out very quickly if somebody is aware of what they're doing. But you can tell experience within them.
For sure. And I think another key thing is if you go to an injector and you point at, I don't know, the nose or the cheek or whatever, and they look at that thing and they go, yeah, it's bulky, whatever, we can bulk it up. If they don't say, okay, when I look at your whole face, actually it's fine. If you look at it individually, you might say this, but actually if I add to your cheek, I think your whole face now is going to be too wide and it'll be too tapered because of the width increase. If they're talking about the whole face and the harmony and the proportion and everything, I think that's a green flag. And that's definitely someone that you should prioritize over just looking at one thing.
Completely. And you see this a lot with surgical rhinoplasty patients.
Yeah.
A rhinoplasty really changes a face. People don't recognize this enough.
Yeah.
Suddenly when your nose thins and shrinks,
your
philtrum's longer, your chin looks longer, your eyes look further apart. The harmony of the face completely changes. They can't recognize themselves.
Yeah.
And that happens with injections too.
Yeah.
Again, being one step ahead of the patient and telling them that. Yeah. By doing your upper face, if you've got a positive vector, you're going to make the lower face a lot worse.
100%. With the shadowing as well.
By imbalance, by profile. And a lot of patients, you need to sometimes show them with a picture.
Yeah.
And something I'm working on at the background, which will take a long time to build, is I'm working on an AI app.
Oh, wow.
Which is the Loomis method. Essentially my logo, which is the sculpting Loomis method.
Yeah, with the face and the line.
Face, it's the proportional Loomis method.
Yeah.
It's for patients and for injectors. And what it does really is it takes all subjectivity out of aesthetics.
Okay, wow.
You come to see me, I could put your face in this app. Yeah. It can break down all your facial proportions, hairline to brow bone to nose, into pupillary distance, filtrum distance. It can tell you how you would look with 6 mils, 7 before you buy it. Yeah. Give you an objective assessment of what's suitable versus what's not. Yeah. So a patient get a realistic expectation of what they can see and expect us to get from the treatment. Injectors can then put that into their CRM system and use that as an objective assessment tool.
Or even potentially as a consent.
As a consent form, So what it does is it takes all subjectivity out of aesthetics. Right now, what happens in practice, patient comes in, I want this, I think you need this, I think I need that, no, I think this. Whereas we can put all that to the side, objectively, here's how you're going to look, here's why I wouldn't do lips, here's why I would do your lower face. That's a good way to streamline the consultation.
Have you got a name for that?
It's the Loomis app.
The Loomis app.
Yeah. So
when do you think that'll
based?
when
It takes 8 to 9 months to code, so it's taking a long time. But hopefully,
so potentially this year, 2026.
I'm thinking next year. Actually, it's just there's lots of hurdles. The coding and algorithm take a long time.
Fine, unless you get another AI to code this AI.
What's that?
See, I think
there's definitely a future to AI in aesthetics.
Yeah, I agree. I think especially when it comes to the compliance side, the boring side, basically, all the paperwork and all that kind of stuff, for sure, definitely. I think in terms of the credentials, I want to just talk about this for a second. Like I said, I could not agree more. And one mistake that I think patients make in choosing an injector, or maybe one mistake they make while they're in that process, is assuming that because someone is this background, plastic surgeon, dermatologist, whatever, because dermatologist is to do with skin, so they must be good at injecting. No, they must be good. Now, in that process, obviously we've mentioned that now, and I think the viewers are aware of our thoughts. Doesn't mean you're going to be any good at all. Plastic surgeon, patients who are asleep, use a scalpel, not a needle. Dermatologists, they look at things like skin conditions, not how to inject to make them look harmonious. But let's now expand that. And we did mention this briefly to non-medics. In the UK, at least, this is a hotly contested topic. For those that don't know who are watching in other countries, the UK is a very unique country in this aspect. In many places, only certain professions can inject. It might be, just medical professionals. It might be just dermatologists, whatever it might be. In the UK, though, legally and technically, anyone can do it. I can ring someone to come and, clean this window, and they can then inject filler into me. Perfectly legal.
Your local plumber can do it.
Yeah, no problem at all. And there's no issue. Biologically, there may be, but legally, there's no issue. So I just want to discuss this for a second. I think we probably have different opinions on this, but I'll be interested to hear your view on this topic. So a lot of people are saying, should non-medics be allowed to inject? Yes or no? You've already said you've seen some non-medics with fantastic knowledge, more than some medics, because they've got a bigger hill to climb, so they put more effort in. What are your thoughts on this? Who should inject debate or topic, if you're happy to talk about it?
Of course, happy to talk about it.
Yeah.
I don't mind talking about it.
Yeah.
Look, I went to medical school for 6 years. I did another 6 or so odd years postgraduate. So 12 years of my life has been committed to medical school.
Yeah.
In that time, I learned in deep anatomical knowledge. I did microsurgical training in part of that, elective work, medical training, learned about drugs, the body in very, very, very high level detail.
Yeah.
So the fountain of knowledge I have as a background is a precedent. It's very high.
Yeah.
So I have knowledge that you can almost argue, coming from a medical family like myself, that,
Yeah.
as my parents would call me, a glorified beautician at times.
It's always family that trick you up, isn't it?
But the point is, I've got a lot of knowledge that I've invested time, money, effort, energy to.
Yeah.
And on top of that, I'm accountable. I'm regulated by a council,
Yeah.
which means if I mess up, they can go to a certain council and ruin my life and career.
Yeah.
Right? A non-medic has a lower stepping stone. So somebody who's a plumber, for example, not even a beautician, a plumber, or a hairdresser, which we're seeing a lot of these days. Lots of hairdressers doing this. No regulatory council. No, I mean, they'll have probably a week's worth of, or days worth of anatomical training.
Yeah.
Yes, they'll learn about a vessel, but as part of conventional medical training, you learn detailed infection assessment. What is an infection? Is it just red, or is it actually an abscess?
Is there heats? All these kinds of things. Yeah.
Is it a vascular occlusion? What are the 6P? Like, what are the things I'm really looking for? And actually, we've had that chance to get needles, intervene, diagnose, assess skin. So if we think of those sort of parameters of what we've done as part of our rigorous medical training, we've had a lot more exposure to different settings where an instrument like a dermal filler injection can cause outside of just being cosmetic.
Yeah.
I'm aware of what telangiectasia is.
Yeah.
Whereas that name might not even ring a bell to a non-medic.
Yeah.
I'm aware of what a granuloma is,
Yeah.
process and pathophysiology behind it, and how to treat it. Whereas a non-medic might simply think that's a lump and dissolve.
Yeah.
I'm aware of what blindness is. I'm also aware of the medication used to treat the blindness protocol, which is like a glaucoma treatment.
Yeah.
Most non-medical people would not even know what the word glaucoma means or how to measure it. I can also prescribe it with a license, and I'm governed to do that.
Yeah.
Whereas if you think of the stepping stones that a non-medic would need to even get that knowledge, they need a medic for prescription.
There almost are no stepping stones, actually. In
Zero.
Yeah.
But for them to access the medication, they need a medical person to prescribe.
Yeah.
The face-to-face consultation, a medical person will need to do that. It can't be remote. To recognize and diagnose, is this rosacea or a VO? Is this subacute VO, or is it a real true VO? Is it necrotis or pre-necrotic?
Yeah.
Is it infected, or is it simply erythematous? There's more foundation that I can work with. So are they comparable? Probably. They will definitely not.
Yeah.
When it comes to actual artistic skill, that's where they should be judged.
Yeah.
Yeah. Because being medical does not make you artistic. It simply makes you qualified.
Yeah.
So I think the hurdle really is the quality of training.
Yeah.
Making sure that people are on the pathway, but not ignoring what's important, which is the clinical safety aspect.
Yeah.
Do I think medics should be injecting? Yes. Do I think non-medics should be? No, I don't. I don't think non-medics should be, because it's almost to many
You think
people,
as a blanket answer, it should be no?
Yeah, I mean, look, if a plumber can pick up a needle, or if a tattoo artist can pick up a needle and do an injection, not just a tattoo, you're comparing to a doctor, which means the public are diminishing or degrading the quality of work I've spent years to learn.
I completely understand
I'm compared to a non-medic being a medic.
Yeah.
So what about my 12 years of training, my GMC certification, all that, all the exams I've sat? What about that?
Yeah.
Is that comparable to somebody who's a tattoo artist?
It's people that confuse their Google search with your multi-year degree.
Yes.
Yeah.
So I would answer that in two ways. Number one, yes, medics should do it, but being medical does not make you artistic. That's my second pronged answer.
I agree.
You need further training to redevelop the artistry, put the ego aside, and understand exactly how to develop artistry, because that also matters.
Yeah. I think I'm in a similar view, but it is different.
Okay, what's your view?
My view is that non-medics can be just as artistic. I think we both agree on that. And that's something.
Sometimes more.
Yeah, completely agree. Especially if they're coming from a beauty background as well. But I think the problem is exactly what you said, which is the knowledge. Now, if a non-medic...
And accountability.
Yeah. If a non-medic was able to somehow get the same knowledge, fine. Okay, they've achieved it somehow, but they've done it. And if there was some kind of regulation or regulatory body or something along those lines, so they could be, stopped if they just go around sticking needles like this and not looking at infection control or whatever, then there's a level of protection there. And if they are doing that, if the knowledge is the same, hypothetically, and they, sit exams and they learn these things specifically for injecting, and there is a regulatory authority for it as well, I think potentially you could get away with it, because I've seen some fantastic work from non-medics, and I've got to admit that, and I've been really impressed, and I think it's brilliant. I see non-medics with a completely amazing dedication to education, because they know they have to if they want to get any kind of respect. And they've been injecting with a great deal of experience now. Obviously, when they first started, they had none. But when you have been injecting for 5 years, 10 years, you clearly kind of know what you're doing at the very least. And I think on that basis, non-medics could be allowed to inject. But for me, it's not a blanket yes or no. It's do you have the right knowledge? Do you have the right capability? Is there some method of accountability? In which case, if I was a member of the public, I would be happy to consider it. But I don't think it should be a complete no, and for another reason. And this comes down to an ethical and a moral side, I think, for me. I don't know if that's the right word, but I think it's a case of free will. If this person wants to choose that provider for work, even if they're a terrible provider and they admit they're terrible and they know they're terrible, but they want to make that exchange amongst themselves, I feel as though I have no right to take away someone's choice. I may not agree with that choice, and I may advise against it, in fact, very verbally, but I don't feel as though I have a moral right, or I don't know if that's the right way of saying it. I don't feel as though I have a right of any kind to take someone's choice away from them. If someone wants to have an abortion, not have an abortion, someone wants to get a tattoo, not get a tattoo, I feel as though I have no right. Now, when it comes to children, obviously it's a different thing, but we're not talking about that here. And in the same way, I don't have a right for them to take away their right to say, I want to see this doctor or this injector. And even if these people are unsafe, let's pretend every single one is unsafe. Yeah, I get it. And you're trying to help them and protect them, all for that. But it doesn't sit right with me to take people's choice away.
Are you referring to patients or injectors?
Patients.
Patients, seeing a non-medical person. Okay.
And it's hard for me to...
I think the choice, I agree with you, the choice should always be there.
Yeah.
But I think there's going to still be, I can't even see how the knowledge base to reach a similar platform.
No, I agree.
It's going to be too long, because dental school's 5 years, medical school 6.
Yeah.
Then there's postgraduate training, and then there's experience dealing with patients.
Yeah.
this is the first dealing with patients.
I completely agree.
And many
Completely
things
agree.
can happen.
And that's why I say hypothetical.
Something as simple as a vasovagal syncope.
Yeah.
And that can either have a range. Some people can syncope mildly, others can start to seize and froth and be incontinent.
Yeah.
Do you just suddenly...
You've got to get the oxygen out. Well, are they going to be able to get the oxygen in their
maybe
drug?
Exactly. So there's lots of even oxygen. You can overdose on. There's so many things that you can go.
Yeah. Do you turn it up too much? Yeah.
Precisely.
Yeah.
So there's just too much to learn.
Yeah.
If we take an intervention into a human body that can go wrong, there's too much to learn.
I completely agree.
So I can't see how we can even make even a 1-year course.
Yeah.
Which doesn't even exist, but like about a week. I think they're a week, aren't they? The fast track ones,
something like that. Yeah,
a day or a week,
which is ridiculous, and
it's not enough. And it's not enough to just give that paramount safety and assurance.
It's enough for an intro. A very, very basic intro.
Which is why we can do that for medical people. Yeah, because they've got that background. Yeah, I agree, and you need more experience. Yeah, but that applies more to a medical person because they've got such a the terminology alone.
Yeah, you can't even have a conversation. Yeah, no, I agree. I completely agree. And that's why I say hypothetically. Yeah. If somehow there was a way for them to get that, maybe they've been studying for the past 10 years on and off. And as a result, they are on par. Yeah. Obviously, not many are going to fit that bill, but if they were, I would have no problem with them at the very least getting involved or trying to get involved or learn or shadow and do things like that. And then if under supervision, they get the practical experience as well, and they do that for a long time, and then they get to a point where, they will do the same job for a patient as someone. Yeah. I think in that situation, there's nothing wrong. But I agree. What are the chances of that happening? I don't think it's massive. But if we get there, I think, the right to choose for me, that's massive. Yeah. And it's an ethical thing. And right now, if a medic is not a very good injector, they don't have the knowledge. Yeah, I'll advise against it. I will say to my patients, don't go to XYZ because I have no idea what they're doing. Yeah. But I won't stop them. Yeah. Because I think, where do you draw the line? If you take that right away, what else you're going to go? I think it stems into a political discussion almost. Yeah. And for me,
a lot of people have the same view as you. So it's a common view. That's the point.
It's a choice thing. And I think the principle is the same in what we think. I think I just feel I'm getting probably a little bit too political in what it means on a national scale. But I agree in terms of principle and what we both want. So in terms of the education right now that is out there, obviously in terms of the fillers that is out there, there's a few major places that, at least in the UK, most people have heard of. I could probably say between 5 and 10 places, which most people have heard of. And then there's lots and lots of small places. Is there an advantage to learning with a big company versus a small clinic where you just go and do a simple one-on-one with someone experienced? Is it worth going one route over the other?
If you're a beginner, I think the stepping stone is more safety before artistry. Yeah. Because if you think of the foundation courses that we used to teach, on the screen, it's mostly words. Yeah. Whereas as you evolve, and the course I teach now, the facial sculptor, is only elite level. It's very high level. Right. It's hardly any words.
So you don't do like a foundation thing, you just do full face?
Not anymore. Obviously, for 13 years, I was teaching at everything from basic all the way to advanced. Yeah. I think it's much harder to teach a beginner.
I agree.
I only now teach high-level advanced injectors who are top of the game around the world. Yeah. A, I enjoy it more. B, it's easier to teach. And C, we speak the same language.
It's less of a headache just talking to them.
Right. Yeah. Now, it doesn't matter where you're from. I had someone from Bali the other day, and somebody who can speak English and Taiwan, and we all speak the same language because it's actually less wording on the slide and more imagery. Yeah. It's more direction because we're here to relearn or optimize technique. Now, I think if you're a beginner, yes, probably learn the fundamentals, safety, do it algorithmically, do it based on precision, learn even aspiration, learn everything. Yeah. And then with time, when you get more experience in your game, go to somebody who you actually admire, you like their work, and you think that person does it all the time. I want to be like that person. Yeah. And then you take it to that level of training. Yeah. Now, in the UK, unfortunately, we're more tight, we're more frugal. We actually don't spend much on training.
No, which is a shame.
Whereas most of the Americans and the Middle Easterns,
different game altogether.
They will really put money towards training. They care about that stuff. They value it. Now, is that because of access to products or being off-label? Maybe. Yeah. But I just feel like there's a different mentality in the US. 90% of my delegates from the US. 90%.
Really? Yeah. Wow. Even if they come to train in the
London, they'll come, they'll shadow, have a treatment, have training, go home on a 5-day trip. That's the common thing I see here. Wow. That's why I go to the US quite a lot. I'm going to Atlanta in 2 weeks. Yeah. I've been all over the US in the last year. Yeah. The demand for training off-label training, non-pharma, non-manufacturer based,
Yeah.
non sort of legitimate. You have to do this type training,
Yeah.
but value expert level training.
Yeah.
And I feel like the US leads the way in terms of the demand.
Oh, in terms of demand, yeah.
Yeah.
What about the quality of training? Do you feel as though, different countries, or any countries that stand out in terms of specifically good or particularly bad training, be it in terms of the level of knowledge, the level of sponsorship taking over everything and ruining it, anything at all?
I do think the US is highly commercialized. I feel like a lot of it is big pharma led. There's a huge litigation-based society in the US.
Yeah.
So if you're doing something without training in it,
Yeah.
you're scrutinized. There's a billboard that have you had negligence issues?
Oh yeah.
I see all over the US.
Yeah.
The UK is a bit behind in that aspect. I think the quality, that's why they take it more seriously, for sure.
Okay.
I think it's not really based on country though. I think that the quality of training depends on the provider doing it.
Yeah.
If I'm going to train with somebody, it's a bit like having cosmetic dental work.
Yeah.
If I'm looking at their work and it's consistently good to my liking, to my aesthetic, not keyboard teeth, not
Wrigley's chewing gum.
exactly right. I'm gonna go with that person. So I think you need to really vet the person. They need to be doing what you want to be. They need to be the person you want to be.
Yeah.
In terms of a business sense,
Yeah.
their whole aesthetic, their approach to selling, their ethics, their price structure, their whole way they frame things. I think that you need to find somebody who is a role model and then actually attach to that person. And I think that's the best way to really evolve. That's the only way. To be the best, learn from the best.
That gives me a very interesting question then. I'm not sure if anyone's ever asked you this.
Who I've trained from.
No.
Okay, all right.
At this stage in your career,
Right.
who do you look up to and think they do great work? If any.
I think people do different things great. Like if we look at someone like Arthur Swift, right?
Yeah.
We all know that name. He's like the godfather of this world.
Yeah.
Now I can say this, is his work impressive to me? No.
Yeah.
Not.
Okay.
Is his presentation, his delivery, his articulation, his knowledge, the way he makes things look so easy, impressive?
Yeah.
Absolutely. I could take a lot from him.
Yeah.
Some of the work in Brazil, we're seeing people like Igor Alves or their work is incredible, but they're using upwards of 26, 27 mils of filler. Now, it looks good there and then, but what's going to happen on the second or third day? Their face is going to balloon up. So I question safety, but the work looks incredible.
Yeah. So if you had to have dermal filler done and you couldn't do it yourself and you couldn't pick your wife,
okay,
which people would you choose from around the world? And it could be any country.
If I was to do my nose, I would visit Ayad Hub.
Okay. Where are they based?
He's in Bicester and Ascot.
Okay.
And he's just...
in the UK, yeah.
Yeah, he's a non-surgical rhinoplasty guy.
Yeah.
But he's perfected the nose. I would visit him.
How do you spell that?
Ayad, Ayad. And his surname is Harb Hub. Yeah.
Okay.
He's a plastic surgeon.
Where's that name from? I've never heard.
I think he's Lebanese.
Oh, okay.
Yeah, but he also happens to be a good friend of mine as well. So
Yeah.
he's perfected the nose technique.
Yeah.
If I was to have, not that I would, but lips, obviously you go to somebody like Judy Horn, who's perfected male lip.
Yeah.
It's hard to say. I mean, I go to different things for different people.
Okay.
Skincare.
Okay.
It depends on if someone's an expert in laser treatment for my skin type.
Yeah.
I'm very fussy and specific, so I'd go to somebody who just does that.
One thing.
I wouldn't go to somebody who does everything.
There's a great lesson in there for the people watching.
Absolutely.
Yeah.
It's a good way to frame it. What would you do? Because you get a lot of people who offer these services, but would they have them themselves?
Yeah.
I would find the person who just does that.
Off the top of your head, if someone said you got to have jawline/chin, and someone said you got to have, say, cheeks, same person,
Surgically?
Non-surgically.
Okay.
For fillers,
Right.
is there anyone that comes to mind at all? If no one comes to your mind, that's fine.
Before I continue, eyelids. If I was to have my blepharoplasty done, Meteshkapadia.
Okay. I would
eyelid.
Daniel Ezra.
A bit too conservative, my liking.
Okay.
If I'm going to go through the downtime and lower lid blepharoplasty, by the way,
Yeah.
much more complicated than upper lid blepharoplasty, which you can do under local anesthetic.
Yeah.
Meteshkapadia in Boston eyelids, he's mastered that game.
Okay. Boston in the US.
US.
Yeah.
If I was to have a deep plane facelift, if I was in my 60s, I'd probably visit Mike Nyack over in the US.
How do you spell that surname?
Nayak. Yeah.
Okay.
He's perfected the deep plane technique.
Yeah.
Andrew Giacono happens to be very good at that work as well.
Okay.
And in the UK, Dominic Bray has perfected deep
BRAY.
BRAY.
Yeah.
So what you're seeing here is, again, I'm finding people who I know just do one thing.
Yeah.
And one thing all the time.
Yeah.
Not this, that, here and there.
Yeah.
Always doing it, which means I've encountered every possible issue.
Yeah.
For filler work.
So specifically, let's take the jawline/chin. If you wanted to augment that for some reason, and let's pretend you were recessed, is there anyone? I mean, the fact that you're thinking about that is an answer.
No, I can't.
That's an answer enough.
To be honest, I can't think of anybody I would visit for that.
What about lateral cheek? And I think the silence again is
again. I'm strong. I mean, Bassam Band does pretty good work.
Yeah,
I like.
I love Bassam.
Yeah, he's a lovely guy.
Yeah.
He's honest and he's pretty good with his technique.
Yeah,
and not only because I've trained him, but because of the fact that he's actually quite good.
I've seen it. He works at Skin Bros in London.
Yeah,
if anyone is interested.
lovely guy, good ethics.
Yeah, but he only treats men.
Yeah, so again, you see, I'm seeing a male, right?
Yeah.
We should talk about the male market in a minute, by the way.
Yeah, we should.
But yeah, I mean, what are you?
It's a tricky one, I think, and I'll probably come to you, frankly. You, or I would also ask, or Bassam, or there's a guy called Amrit Tiara, ex-colleague of yours, Thiara. In fact, he was in the podcast before, well, sometime last year, which will be on my channel recently. I think they're very, very good. Arthur Swift, if I needed something subtle, I wouldn't mind going to Arthur. To be honest, there's not many people at all.
People are, yeah.
I can count on one hand the people I would go to, and you guys that I've mentioned are probably the only ones that I'll drop your text one day when the time comes.
So the male market, let's talk about the male market then.
Yeah, well, just before we do that, one final question I've got for you. Tear trough, is there anyone you would go to for that non-surgical tear trough filler?
Non-surgical, again, I like Bassam Band's blending technique. He does subcision with very soft products.
Yeah.
Nicola Lowry in the USA.
Had Lowrey. Okay.
Or Anushka, I don't know her surname. Anusha.
Yeah.
Over in the US as well.
Okay.
Phenomenal cannula with nearby cannula, and they blend it nicely too with a 1-to-1 dilution. I quite like what they do.
Dilution. Okay.
Yeah. So sometimes
you dilute.
Sometimes, I mean, what I've been doing recently, which has worked nicely, is I get a very, very soft HA filler.
Yeah.
In the right candidate with good skin quality, and I blend it with a polynucleotide like Vitarin or Plinest.
Sometimes you get a higher reaction rate when you do that.
Okay.
Yeah. So be very, very careful. If you haven't had one yet,
I haven't had one yet. No, but
I would say if anything does happen, give me a ring. Happy to help.
Okay.
Because sometimes what happens is when you have those things, what's in the polynucleotide when it breaks down, right? It breaks down because polynucleotide as a whole doesn't actually do anything. It's DNA, right? DNA is in the cell, not outside. So we have no cellular receptors for DNA. So it only does anything because of its catabolism. It's broken down. So the question is, what are they broken down into? There's a few different things. And one of the things they come down to is inorganic phosphate. What do we get? What do we need to keep us alive? Things like ACP, adenosine triphosphate.
Right.
So if you have a certain amount of ADP in the cell, adenosine diphosphate, the breakdown of the polynucleotide or the catabolism of the polynucleotide provides an element of inorganic phosphate for something like the phosphocreatine system to recreate the ATP, so the cellular function can improve or increase or whatever. That's one of the reasons I would say polynucleotides create some sort of change. However, you also get other things like pure nucleotides, etc., etc. And the way these are triggered with the A2A and the A2B receptors, it actually limits the range of protein output the cell can produce. And I mean, there's not enough time to go through it in detail in the podcast, but I can prove, and I have actually on stage in front of, I think it was Derma Focus, that you cannot produce as much as you would want to produce if you use a polynucleotide.
Right.
And I did that to their face, and they didn't say a single word.
I'm sure they would have...
because they know absolutely 100% correct.
Right.
Sometimes you could actually theoretically lower the output if you combine the HA with the polynucleotides, depending on the molecular weight of the HA.
I see. Okay.
And where it's come from.
Right.
For example, the filler company that HA comes from, do they take the delivery of their filler in powder or fiber form?
Amazing. I've never asked the question.
I've never heard anyone ask it either.
Yeah, I certainly haven't.
But it makes a difference.
Okay.
To all these things.
Right.
And again, this is what I teach when I teach skin, and everyone sit there thinking, God, why does no one else teach this? Not that I'm trying to big myself up, but I get that feedback. And when I do it, they can spot all the BS very, very quickly after. It's like a driving school for the aesthetics world. But yeah, if you ever want to add skin to sculpt, happy to chime in.
Why not? Why not? Yeah.
And that'll get some things in there. But yeah, combining, if you're going to, sometimes it will work and sometimes it won't. Sometimes it will lower. Sometimes you get a better effect if you separate. Depends on.
Have you ever blended with saline?
In tear trough.
Tear trough or even other parts of the face?
I've done it with forehead and tear trough and lips.
Okay.
And that's it. Well, I'll just use one of those
Punctures, yeah.
Yeah.
People with radius. I mean, people with radius would often hyperdilute radius.
Yeah.
And put it under the tear trough too.
Yeah.
To improve the color and
I know.
skin texture. I've not done that.
No,
I worry,
and I never would.
My worry is always with a product like radius.
Yeah.
Is the you can't reverse, even with sodium disulfate, which they say has impacts. Is if someone doesn't like it and I can't get rid of it, even if it looks good, what's going to happen later? And if they don't like the result,
100%.
that becomes an issue for me, reversible. I like things I can remove.
Yeah, and it's unpredictable in terms of the reaction. Obviously, there is an element of safety, of course. If it wasn't, it wouldn't be sold. But this is not a trick question I'm going to ask you now. Where do you find calcium in the body?
Bone.
Hard tissues. Bones, teeth, things like that. Yeah. Where do you not find it?
Skin.
Soft tissue. Except in what circumstance?
When you get trauma. Calcification.
Exactly.
Scar tissue.
Things like atherosclerosis, cardiovascular disease.
Trauma,
It's only meant to be in the hard tissue. So when it's in soft tissue, I'm going to be really nerdy for a second. Apologies to anyone watching this. When it increases the level of inflammatory markers, it actually has an inhibitory effect on the tuberous sclerosum complex, which is within mTOR and controls mTOR complex 1 and complex 2. At that point, you get a hyperactivity result, which is why you get the limited range of proteins that you do, same as polynucleotides. And there's a fibrosis risk as well, which again, no one teaches and no one explains and no one can tell me I'm wrong on because it's just a biological fact.
A fibrosis risk with obviously these
nearly all biostimulators.
This is what many surgeons say when it comes to facelifts. It complicates a facelift.
Yeah, and the reason is when you work in it, you've got a particular injectable, you got the skin. You want a particular output from the skin. Fair enough, of course we do. But depending on how the cell and this product interacts, you immediately limit which protein you're making. And if you limit which proteins you're making, hint, nearly every product in the world is collagen 1 and 3 for a reason. At that point, what part of the reason is because of the way you are interacting with the mTOR pathway. If you want to look at it through lenses or other perspectives as well. But when that happens, you can also lead to a hyperactivity of the complex 2.
Right.
And at that point, that's why you get the fibrosis risk. That's why with polylactic acid, surgeons don't like doing facelift afterwards. Or even with, if you do thread lifts, I think thread lifts can be done okay if you're the right person and the right patient, but they don't like doing facelift after thread lifts.
Fibrosis scar tissue.
And again, people need to understand, this is why I have my YouTube channel and try and do my own courses. People need to understand why the mechanism. If you understand that mechanism, I guarantee you, all other people that I've taught over the years, they can look at any products in the world, even ones that haven't come out yet, they can tell you in 2 minutes what's going to happen and whether or not it's worth it. And I think that type of education is missing as well.
Sure, makes sense. I mean, it's amazing. I didn't know that either. So
well, no one teaches it. Maybe there's a thing we could do somewhere where you do the fillers and I do the skin. But anyway, let's talk about the male market. This is obviously coming up really big. Our mutual friend Bassam does a lot of this. Skin Bros London, check him out. What have you noticed over the years in terms of the male market?
The male market has shot up. I mean, even in parts of the world like the Middle East, where it was frowned upon, is now in demand. And the male,
it was frowned upon.
Because in the Middle East, men having cosmetic treatments was something that was it was more of a female thing to do rather than a male.
Oh, I see. Right. Okay.
And in the Middle East, Arab men typically wouldn't pay attention to these things. But two things have triggered it. Number one, dating apps.
Okay, right, wow.
And something called Looksmaxxing.
Oh, I know Looksmaxxing, I've actually got a video coming soon about that.
Well, I'm on a forum with that stuff, so I know a lot about that stuff. There's dangerous practices to Looksmaxxing.
Oh yeah, don't hammer your face.
Bone smashing.
Don't do that. And that's in my video coming up as well,
But Looksmaxxing is a big one. I mean, people overdoing the self DIY injections of hormones, but the bone smashing.
I've had patients come to me when that's gone wrong.
I mean, people doing biomax surgery prematurely young, testosterone treatment very early in life, androgens, and also the other thing is height.
Limb lengthening surgery.
So this Looksmaxxing trend is becoming a little bit dangerous for young men. But what's triggering it, believe it or not, is dating apps. I'll tell you why. Because I see 50% of my workload is male.
Oh, really? Wow.
50%, a high proportion of treatment I see is male. I think I'll probably treat more men, probably Bassam too, but I treat a lot of men in my practice around the world. And the male approach to aesthetics is very different to the female approach. Like when we go shopping with our wife, like when I go shopping with my wife, she'll try on 100 dresses. She'll be back. She'll be there for 4 hours.
This may not end well for you by the time she watches this.
And she knows it. She'll be back the second day. There'll be returns. They'll be back the next week. What do? We go, we have it. We're not coming back. Whether we like it or not, we're going for it, right? The level of impulse, the returnability, the risk element of it,
Yeah.
it's higher in men. And men actually can look good with high volume aesthetic.
Yeah.
Now, dating apps have triggered it because on dating apps nowadays, believe it or not, women are more fussy on dating apps. They have more criteria, certain looks, certain status, height, all these things.
Yeah.
Whereas men only care if they're attractive,
Yeah.
right? So now these young caliber men,
I'm on Tinder as well. So
well, Tinder too, right? Do you know Hinge? By the way, you can filter based on income and height,
Oh, I didn't know that.
and then based on hair.
Right.
So they're really pushing the algorithm. There's all these new dating apps coming out where you can really hyper filter.
Right.
Now, what's happening is it's harder for I don't know if we can go have a discussion like this.
Please.
But
Yeah.
men control access to marriage. Women control access to sex.
Yeah.
Right. And men are now competing. Your younger guy, the Looksmaxxing bro, is competing with the average 50-year-old billionaire in Dubai, who's a Russian oligarch with 100 attractive women around him. So they can't compete on money. But they can compete on appearance.
Fine.
And actually, we know statistically that men are being screened out if they don't earn enough, if they don't look a certain height, if they don't look a certain way, if they're not. So it's called the black pill movement. Have you heard of that?
I have. Yeah.
Blue pill, red pill, black pill. It's a whole lot of podcasts. But looks, whatever people say, matter for the male, and actually anybody looking for a job or employment. And there was a little test, a trial they tried where they got one lady and two guys to approach her, one below average looking, one guy very attractive. They both said the same comment, right? They made the same approach.
I can guess what happens.
The less attractive guy was considered harassing her. The attractive guy got a number on a date. So this just shows that, what women say and what they respond to are different things. And looks do matter. And actually dating apps statistically, criteria proves that.
Right.
So actually these younger guys, and I see a lot of them trying to just date, trying to compete on attractiveness.
But do you find as though sometimes, as far as an injecting point of view, do you think that can be a little bit of a difficulty because they're not coming for filler per se, they're coming for a date? And if they don't get that, do they come and have an issue with you?
Not really. I feel like honestly, men respond well to feedback. I feel like feedback isn't given enough to men.
Okay. In what sense?
From women.
From women.
If a woman's gone on a date, they met on Hinge.
Yeah.
Why was he not successful? They don't want to upset his feelings.
Yeah.
You went this, you went that. Tell guys straight. Yeah. You can shame a guy. If you can shame a guy, he'll improve. Yeah. He'll optimize, he'll blow up.
Yeah.
I feel like, we can't give that same feedback to women.
No, not without getting chastised on social media.
Precisely. But we can with men. You can shame a man. Being overweight or unattractive, get your money together, get your business together. He will take that and he will learn from it. I feel like if that happens more, like it's happening now with this whole Looksmaxxing trend, men will go there. Men will break their legs to get taller. Would women do that? Probably not. Would men even break their legs or do these things if it wasn't for women? Probably not.
So that's a great question.
The insecurity is there for female attention, female attractiveness, right? And women statistically control access to that because even a below average looking woman is now more fussy because women date up.
I never thought about that.
Ask any woman. Would you want a man who's more attractive than you? Taller than you? Earns more worldly, more competent.
They'll always say
Attractive, I'll probably put aside, probably that doesn't matter. But they'd always want somebody they can learn from. More accomplished, earns more money than them, stronger, bigger build, confident, worldly, assertive, a leader.
Masculine, right? If I'm allowed to say that word, don't shoot me. Kind of.
I mean, I'm judging this based on my practice, right? But women, I've noticed, will date up. They won't look down. They won't date somebody.
Even when I used to be a dentist, I haven't done it for years, but I saw the same thing. Now, a woman would come in for this work or whatever, and the guy would sit there with his Rolex watch or whatever, sorting some business out. She hadn't got a clue about business, but he was just funding it all.
It's why in the dating world, his future matters and her past matters. Men sell success, women sell purity. Right, and that's what's happening in the world of dating today. I'm literally at the forefront of this because I'm the guy they come to date.
To achieve that.
I feel like I get a lot of Looksmaxxers and Hinge profiles and all these, and they're all in that game to optimize, right? And I feel like the earliest way is looks. Because it's the open door. It's the gate access pathway.
100%.
And a lot of these guys simply care so much about, to the point where it's obsessive.
Yeah, no, I agree.
We know it's not healthy.
Their life revolves around that at that point, and things suffer, like their job or something like that. And it's sad to see, but at the same time, I think, well, if I'm in a position to help get them out of that and make them happy and get on with their life, maybe I should do it and help. So everyone that, I've had Looksmaxxers come to me, not any Looksmaxxing influencers or anything, but people that clearly are doing it, and I've been happy to help.
Yeah.
Because if you can tick one box, if I augment their cheek, I know they're going to go home now and they're not going to hammer their face anymore.
Yeah. Yeah. I think the key thing here is with these younger Looksmaxxers, some of them start very early, is recognizing the distinction between what's obsessive and abnormal and being like quite realistic with expectations. Because some of these guys, it's their world.
Yeah.
It's their world. They'll put all their money towards it.
Yeah.
They will travel. I had a guy come from Toronto the other day for the day.
Yeah.
Do everything and then go home.
Wow.
Now, I need to assess, is this a level of obsession or is he being realistic? Because we know when it's obsession, anything that's obsessive becomes a disorder, which means they can't function socially, they can't talk to people, they can't go to work, they can't look in the mirror.
Yeah.
It affects their day-to-day functioning.
Yeah.
That's the first thing I would scream.
Yeah.
If they're okay to function socially, I would go there. Then are they realistic with the outcomes?
Yeah.
Some of these guys could be hyper extreme with
Oh, I've seen. I mean, I'm not on any Looksmaxxing forums.
I didn't know I was until recently.
Yeah.
It was shared and suddenly I had this tirade of young guys coming in. But yeah, it's a big trend. I'm discussed on the forums quite a lot. Looksmaxxing.org.
Looksmaxxing.org.
It's quite an interesting forum.
Yeah.
Some of the stuff they talk
You know, I think I've seen that.
Okay.
I think that's the website I saw. Yeah.
Okay. All right. There's an app as well.
There's an app.
Yeah.
Oh, I didn't know that. Okay. I'll have to have a look. Yeah, because I've had people message me on Instagram, and I think 2 years ago or something was the first time I came across that term. I thought, what the hell is this? And it's a massive movement.
It is a big movement. And there's a lot of, the community has got 50,000 members around the world.
Yeah.
And this is like a new thing.
Yeah. And I've seen some horror cases.
Yeah.
I've had messages from people. I'll never forget this. And I hope you're okay if you're watching, but I had one guy, he was face hammering. And you can guess what happened. He went right on the zygomatic arch because, you know, the zygomatic arch, for those that don't know, it's not the same thickness throughout. Where it meets the face and it goes back here, the bone just kind of spreads out a little bit and sort of cross section is bigger. It's a little bit thinner in the main portion. He was doing it hard, thinking the harder I do it, the more it's, he ended up breaking the zygomatic arch here. He was too embarrassed to go anywhere. And I was just like, look, you need to get to A&E, you need to see Max Facts, you know, call the hospital ahead of time, ask for the SHO, tell them, look, this is what I'm coming in for. Can you get someone to help, whatever. That's going to be something like a rose elevation or something in a Max Facts department. And when I saw that, I thought, okay, this is serious. Like, we need education.
It is. And do you know what? I put a post on it recently about Looksmaxxing, safe and unsafe practice. But if we think about why it's happening, it really is because of this whole, you know, materialistic dating world that we're in.
Yeah. No, I agree.
World.
We do it for the other opposite sex.
And you know, what happens? 95% of men are invisible on dating apps.
Yeah.
And what happens if they don't do this?
Yeah.
They resort to drug and substance misuse, mass shootings. You see all these unhappy, disgruntled young men,
incels,
who turn to violence, right? So while it needs to be made more safe. I feel like the Looksmaxxing world, which has definitely taken off because of this, needs to be optimized in terms of safety. Yeah,
couldn't agree more. In terms of when you do treat a man, okay, let's put Looksmaxxing to the side for a second. I think we would both agree, in fact, probably most injectors would agree, you don't analyze a male face in terms of the proportions the same way as a woman.
Absolutely not. The skull shape is different. The bone structure is different. There's a huge diversification. There's a huge dimorphism between men and women. Yeah. And it's so easy to feminize a male face. It's so easy.
I see novice injectors do it all the time because they learn on women and that's all they've got experience in. So they assume you do it to everyone. No. And they look
and it's so easy to get it wrong. And actually, you know, the biggest giveaway is the eye, actually. But I talk a lot about this in my courses.
Sure. Don't give too much away.
I won't give too much away, but it's the eye area, the lower third of the face.
Yeah.
It's so easy to get it wrong. And I guess it's a one trip pony because look, men often don't like to look done.
Yeah.
Because men often like to look less tired. Because when they look tired, they look weak.
Yeah.
So the aim is to look more strong and healthy. Yeah. And that fine line between overdoing it can sometimes feminize. And I feel like that isn't really taught enough. And especially a lot of men tend to visit men. They don't visit women because the understanding and approach to the male face could be quite feminized.
Yeah. And some of my male patients even said, you know, I just wanted to go to a man.
Yeah.
Because they can even speak about things, you know, so some of my male patients, you know.
Without judgment.
Yeah.
Yeah.
Because, and when I say, when we developed that rapport, they then start telling me, yeah, I've been getting TRT as well. You know, not in the legitimate way, shall we say? I'm trying all this stuff, and you know, it's not necessarily Looksmaxxing, but it's a great deal of obsession about themselves. And I'm not sure they would have come out in that way if it was a female injector.
So next time you see a guy, ask him why he's doing this. The honest ones will tell you it's often being it's it's when they're hurt from a relationship or they succeed with women.
Yeah, I've seen that in women as well. Yeah, or on a rebound perhaps, or something like that.
I feel like a lot of the guys I've seen, whether they're middle-aged or young, it's related to women.
Yeah.
It's why they do it. We wouldn't do it otherwise.
I completely agree with you. Like if you were the only person left in the world, would you be doing that treatment? No.
I mean, I certainly want to break my legs and make myself...
No,
There's
exactly.
a guy going viral right now. You've seen him, Le Trembler. He went from 5'7".
Oh, I haven't seen it, but someone sent me a link. I haven't looked at it yet.
He cracked his femur and his tibia. He thought Guinness World Record. He gained 20 centimeters in height. But he's never going to be normal. He's walking around with crutches. There'll be
It's going to take a long time for his nervous system to learn.
And his muscles to adapt and stretch, his gait to normalize.
It's going to take years.
You don't think about these things.
You
jump into that impulse of
think about how long puberty takes. And as you're growing in that state, like to learn everything. Some kids, I remember in school, they used to run in a really weird way and I couldn't work out what was going on. And I really, looking back, I realized, well, they had a growth spurt. The brain hasn't had time to catch up. That's what's going to happen here. They're going to look weird in terms of their movement.
And also, I wonder, if you're cracking your legs and learning things, how is that proportion going to work with the upper body and the arms?
And
the feet? Imagine.
Exactly.
Like a
sort of comic character or something like that. Yeah. It's
I was going to say giraffe, but that's the opposite way around.
Yeah. The opposite of a giraffe.
Neck maxing.
So when you look at a male face then, obviously don't give away everything that's in your course, but from a general public perspective, there's probably men watching this who think, oh, I didn't realize I could be feminized. I thought everyone knew what to do. What steps can a male viewer going to get injected take, or what kind of things can they watch out for to know, oh, don't inject too much in this place, or make sure you do this and this, etc.
Or what suits a male proportion, essentially. What's a male proportion guideline? Without giving too much, I'll be very specific with these things. Typically, what you want to be looking at is your zygomatic to bigonial width, your jawline to cheekbone dimension, making sure they're aligned 1-to-1 as opposed to a narrow lower third. Definition and width to the lower third of the face, a mouth corner width to the chin, a 1-to-1 upper lip to lower lip, not a 1-to-1.5 with more width, and particularly around the nose and the eye like a thicker eyebrow, low brow margin, a neutral canthal tilt as opposed to positive. Try not to over-tox around the eye because otherwise you lose expression and tilt the arch. And you feminize the male face. A strong compact mid face with a big facial with a longer or a higher facial width to height ratio, meaning there's compactness to the mid face. A nose that's got a high radix but not overly tilted.
I think in the nose, men can get away with a bit of bulbosity as well, whereas women can't.
And same with the over tilt and the radix. You want to have strength to like a romanized nose. A strong forehead sulcus is a male feature. Character lines, static lines. It doesn't have to be too perfect, but like I said, there's level of obsession with these things. Where they take it further, and that's how they go wrong. A narrow pointy chin, a high arch cheekbone. Like the human Ken doll. Again, some people like that look, but if you look at the dimorphism,
very niche.
It's a small minority.
I mean, you look at people who are large, not in terms of obese, but in terms of frame. None of them are going to have a petite face.
No.
And you typically look at them and they look quite masculine. Even if you can't put your words on why, you just feel an element of masculinity in terms of the visual. They're square. They're blockish. They've got sharpness. It's not smooth and rounded and svelte and V-shaped. It's blocky. So in terms of learning then how to inject the male face, do you think that at a foundational level, people should be learning that difference instead of just learning area by area?
No, I think they need to learn technicality before they learn artistry. Otherwise it confuses them because you get to a point where you're then not looking and you're appreciating, whereas they need to start by looking at quantity, dose and safety. Learn individual. I mean, I would only train somebody on this level of course when they've addressed every part of the face, when they've know how to inject already. So technicality comes first, artistry comes second. So I think, don't learn all the beautification, feminization, masculinization, profiling. That comes later.
And do you think...
Walk before you run.
Would you say that it's more difficult to treat one gender over the other? Because some people are going to be watching this, wanting treatment and thinking, am I at higher risk because there's less people who are good enough to do it?
Not necessarily. It depends on how many you do. I think actually ethnicity variation is male, female. I'm doing two things at the moment in my next few conferences. One is a mother-daughter transition. Everything look the same age. Another one is the 4 ethnicities. So an Asian face, an African face, a Mediterranean face, and a Caucasian face. So the approach to each one, because obviously proportions in Korean or Asian faces often naturally wider but naturally flatter. So your approach should be varied according to ethnicity.
Yeah.
So there's a level of cultural diversity.
That's a great point.
So I think that's harder than doing male or female, because you can work with certain male-female proportion. And the easiest way to do that is to look at attractive celebrities, the best looking male, best looking female. What do the public perceive as attractive?
Yeah.
Replicate that.
Yeah. And in terms of the ethnicity, again, don't need to give any away what's on your course, but could you give an idea as to why that's important? Because some people will be watching this, maybe of different ethnicities, and that will be the first time they've heard that. Maybe a certain ethnicity of someone watching this and they've had a treatment and they can't work out why they don't look as good as their friend.
Typical proportions in most Asian faces are what we call a type 2 negative vector, meaning they're proportionally wider. So most people from Korea, Japan, China, that part of the world, even Eastern Europe, in Russia, their face, and even Denmark, the bone structure is naturally wider.
A little bit flatter here as well. Yeah.
If you're going to treat them the Caucasian way, which is the contour, you're going to create a spongeable, boxy looking. It just will not. It will be disproportionate and look unnatural and unwavering. Whereas typical narrow, if you look at Mediterranean faces, they're often narrower, recessed. The noses are more of a.
Yeah, I was going to say more verbosity in the nose as well.
The approach is complete. You can work on the width and the contours, because the faces are type 3. They're often oval and long as opposed to short and wide.
Yeah.
And the projections are very different in terms of Asian versus Caucasian.
Could you talk a little bit about ethnical differences in terms of lips?
If we look at the Middle East, where beauty is completely, it's a whole concept of beauty. It's very different to the UK.
Yeah.
In fact, interestingly, whenever I see a Middle Eastern mother comes with her 14-year-old daughter, what does my daughter need? Versus a Caucasian mother, like, my daughter needs nothing. She's 18, 19, she's too young. There's a very different ideology of beauty in the Middle East versus the West. Lip, for example, lip enhancements, it's all subtle and detailing in the West versus fullness in the Middle East.
Yeah.
In parts of Africa, a fuller body habitus, a fuller lip is considered more attractive.
Right.
So larger bodies. Whereas in the West, it's narrow.
Okay.
We also see the same with skin color. If you go to parts of India and Pakistan, fair skin, light eyes, attractive. Middle East too. They bleach.
Yeah.
In the West,
you want to be darker.
Tanned.
You want what you don't have.
Everybody wants what they don't have. Everybody wants what they don't have. It's classic. I see this globally.
What about lips in terms of the Far Eastern areas? Is there any particular trend style?
Interestingly, lips in the Far East are not as much desired. Skin care is number one, followed by surgical, like eyelid work,
double eyelid,
orthodontic realignment.
Yeah,
fillers aren't as popular in the Far East.
Wow,
interestingly, that's more of a surgical and skin care. That's where that dominates.
Yeah, especially South Korea. I think that's probably the plastic surgery capital of the world.
Number 1 in the world, followed by South America, followed by the US, followed by the Middle East. Top 4 in the world.
Fine.
We're fifth.
We're fifth. Okay.
Yeah.
That sounds about right, I think.
Yeah.
So in terms of lips, obviously there is going to be a difference then, not just in ethnicity, but also in gender. I think this is, if men are going to have it, some men are okay with saying, I had this cheek or jaw or whatever. I don't think many men would be happy. If they have it. Do you see a rise in men being happy to have lips?
It's interesting because I'm not a very common lip injector. I think I did 6 lips last year.
Wow.
For me, lips are icing on the cake procedures. They can ruin the anatomy if they're not done as part of something.
Especially if you do them first, it looks weird on some people.
They can impact everything. The radial lines, migration risk is high, recessed chin, shadows.
Yeah.
With a male lip, it's all about width and squareness. And again, you have to be very suitable.
Yeah.
I mean, your upper lip has to disappear when you smile.
Yeah.
Because it's so easy to feminize a male if you do lips when they not need it.
Yeah.
Because lips are one of the commonest feminizer procedures in the market.
Yeah.
Women, it's more about the centrality and the heart-shaped appearance, the fullness. But yeah, you get the odd bloke that does want to have their lips done. But I'll be honest, I don't think I've done 1 pair of male lips in my career, 13 years.
Wow. Okay.
And I did 6 lips last year. I'm not a common lip injector.
Okay.
For the viewers at home, it's not something I do much of unless it's part of something.
Okay. So I want to talk about that one male that came to you just out of interest.
Right.
Did you suggest it or did the patient suggest it?
He suggested it, but he literally had 0 volume.
Oh, okay, fine. So it's understandable.
And it was understandable. I knew I could make it look natural without feminizing.
Yeah.
He's done it before years ago. So it was a repeated pattern.
Okay, fine. Yeah. In terms of the overall average trend amongst your colleagues and things like that, have you noticed a change amongst them or in general about male patients and lips?
Again, if we look at most of the people that treat men, I'd say very few have lips.
Yeah.
That's what I've noticed.
Yeah.
It's not a common one amongst men, I'll be honest. It's something they often don't think of.
Okay. I should probably get Bassam on this podcast, talk about male specific treatments. So yeah, that's interesting. So men overall, they do need a different way. They need a different type of analysis and therefore different, volumes, angulations and things like that, without giving too much away. But I agree. It's not more difficult. It's just different in the analysis, and then that's it.
Yes.
What's difficult actually is, like you say, understanding ethnic differences, even age differences. If you're extremely old with a lot of wrinkles around the mouth and and you want lip filler, okay, fine, do the lip filler, but it's gonna look so odd.
Correct.
And really, really weird.
One thing I would mention is my approach to injecting a male varies.
Okay.
I move instruments a lot. For example, with a cannula, I would put the cannula in, realign it down, and I would do a lollipop technique, bolus and thread. Same with from the traders. I'd pull it in, out, bolus, thread, and I would use the needle with what we call a tripod technique. So I inject in 3 planes. So I would dual plane always with a male. I'd often put both needle and cannula here. In a woman, one or the other.
Okay, fine.
So that's one variation in technique with the jawline, which I feel like a lot of men can.
So you go periosteal on the bone, as well as, say, superficial fat as well.
With a cannula. And I put the needle in 3 different planes because they do different things. A needle this way makes your jaw wider. A needle this way elongates the ramus and inferiorly drops the angle of the jaw. So the way you inject is the way it grows.
Yeah, and I think that comes down to a lot of the injection biomechanics as well, and what happens when you're moving it, which direction the negative pressure is, and things like that as well, which I'm sure will be on Zack's course, so you won't give too much away today. So another thing I want to talk about is, you mentioned it already. You mentioned certain, not fillers and toxins, but other skin injectables. What are you tending to use right now? I know mainly you do fillers, obviously.
I put people on a journey. So when they come to see me, I do all the deep structural architecture first. So they'll come with all the structural work with the dermal fillers deeply placed first. I would then finish in round 2, which is a couple of weeks later, with some regenerative polynucleotide or Profilo. Which I've done lots of skin boosters in the past. And then round 3 is skincare, whether it's a peel, laser treatment, microneedling. So that's a triple phase approach.
I would love to show you Synacos one day.
Do you know what? I hear a lot of patients asking about it. I know it's great for the eye because Profilo can't be used there. I think I've even used it once. But I'd love to see that because I feel like the demand in my clinic is
I will come to your clinic one day.
Show me that.
Just show you.
I think you did that with Carwell, didn't you? And
yes, I did. Aaron.
Aaron.
How do you know that?
I saw on his page. I trained him on it. So.
And big shout out to Aaron as well. He's got the most baby face I've ever seen. And he's got only one facial expression, which is this. Everywhere. I'm gonna send this to him and let us see. Carwell Aesthetics in London. But yeah, so in terms of those things, do you have a preferred order? You said that you always prefer to do fillers first and then
not always. No. The skincare is if the skin is really weak. I mean, you don't want to be injecting a bed sheet. You want to be injecting a duvet. So it retains the filler. If the skin is lost cause, is pigmented and thin and crepey, it's not going to hold the filler properly. So I would probably push them for the laser first. Big fan of CO2 ablative, Moxie or BBL first.
Oh, fantastic.
Vascular laser, IPL and pulse dye. So if it's red or erythematous, then I bring them back to me a few weeks later, and I do all the structural work. Sometimes when you do that and you do ablative work, you often don't need to do the Profilo or the skin boosting or the polynucleotide work.
And I think it lasts longer than those things. Well,
it's a good remedy.
Especially if they're a much older patient.
A lot of surgeons actually do CO2 ablative after a facelift, so you get the dual effect of lifting and tightness.
Have you ever looked into the ultra-clear laser?
Yes, very effective. Pico and ultra-clear is a good combo.
Ultra-clear, I think, is going to take over in the next few years.
With Pico or without?
I've not seen enough with Pico to form an opinion.
In the Dubai, what we do is we'll do Pico and then 2 weeks later the ultra clear. Combination really looks great.
And Pico for the pigmentation and things, big sure.
For the thickness and the firmness.
I've got no problem with that. I think that's absolutely fine. And if you have a BBL and ultra, I think will be a fantastic combination as well.
Are you not a fan of CO2 ablative?
I think CO2 ablative has its uses. I've got nothing against it. But I think with what we can do with ultra clear now and actually remove skin without surgery and just a week's downtime.
It does most of the job, to be honest. So exactly. You tackle most issues.
And you can do it more than once.
Downtime, pretty aggressive downtime.
Oh, you mean CO2?
CO2.
CO2, So with the ultra clear, what I'm saying is it's not gonna replicate CO2 exactly, but you can have another one. A couple of months later, whereas you can't with the CO2. Which I think is a massive advantage, and less risk. I think you're not basically
the PIH risk with CO2 in some skin types. I've seen they pigment a lot, but it goes. But they do pick. I've seen some hyperpigmentation.
I want to say something controversial now. I think there's other reasons for that. When you look at what's happening in PIH, people talk about higher Fitzpatrick skin types and darker skin types being prone to it. Yes, however, I've got patients who have had it and nothing has happened. Yes, I haven't treated every patient in the world. I know
darker skin types.
And they've had nothing, even microneedling, nothing. But I treat them for diet first. So when we look at a study, I mean, there's studies like where, I forgot, I'm really embarrassed. I can't remember the reference, but they had some mice, right? Yes, I know it's mice, but understand the mechanism. Some were fed saturated fats only in their diet. The others were fed unsaturated fats, which is what we're told to have. Only this group, when exposed to UV radiation, developed skin cancer. Same radiation, nothing happened. And I think it wasn't just skin cancer, but other skin problems as well. I might be wrong. Someone comment below if I am, but you get the effect of what I'm trying to say. When you look at darker skin types, like Philippine, I'm from India. I was born in India. And if you look at people in that region, taking it as an example, full of unsaturated fats, full of carbohydrates. If you have that in your diet, when your body is utilizing fatty acids to produce structures, such as phospholipid bilayers of cell membranes, the lipids that are there, if it's saturated, it's perfectly straight. If it's unsaturated, there's a kink, whether it's a cis or a trans double bond that's created between the carbon atoms, which means there's 4 electrons between the carbon nuclei. And because there's 4, it's possible for one pair to actually be lost and go in 90 degrees this way and form a bond onto something else, which is oxidation. When that happens, you have oxidative damage, that can be caused as a result of that. What is melanin? Melanin is an antioxidant. It is a defensive chemical that is released to protect itself. When I used to wear sun cream and on my old diet, and I go outside, even with sun cream, I used to go dark. Now I don't wear sun cream at all. I never get dark.
Because of your diet?
Because of the diet, because there's no unsaturated fats in there.
Not primal diet.
Carnivore diet.
Carnivore diet.
Yeah. You don't have to go fully carnivore, but you have to understand it. And, my patients one patient I saw, they had PIH. We treated it, and then they went for another laser. And I said, I can't guarantee you won't get PIH, but I'll be surprised if you do. And I said, no, I fully understand and appreciate what you did. Nothing happened. I know that's only one person, and it could have been a fluke. Completely agree. But we cannot ignore what's happening from a chemical perspective, because yes, we talk about that study was mice, but in terms of the oxidation and the electrons, that's nothing to do with the species. That's just chemistry and physics at the end of the day, and that's universal. And so this PIH risk, there is no paper in the world, and I guarantee you this, that has studied PIH and has taken into account the nutrition. If they were to, somehow, I think they would find something very, very interesting. And when you take into account that people who do venture this way, you're going to see massive improvements. When you see people, I've had patients who have had poor quality skin, no skincare, no skin treatments, just change diet, they're like a different person.
It's approved it. Makes sense. Endogenously.
Yeah. And so I think the PIH that you get from CO2, I don't think it should be something to put people off CO2. I think it's something to do before CO2 to minimize the risk.
You should have a chat with Dr. H. Consult Asif Hussain over in Central. He's quite hot on this
in
stuff.
Leeds.
Dr. H. Consult he's quite hot on.
As in which city?
He's in Harley Street.
Oh, he's in London. Okay, well, just round the corner then.
He's big on this stuff too. So
okay, do you know him personally?
I know of him. I've met him once or twice, but but yeah, you should check out his page as well.
I mean, do you think that they agree or disagree with me?
I think he'll be one to challenge, because he does a lot of CO2 ablative for high risk darker skin types as well.
And I'm guessing he's okay with it.
Yeah, I mean, he's definitely, he even risks PIH and a treat it later.
Yeah.
So you'll see he'll have different views on that.
I think there's nothing wrong with that.
Yeah.
And
patients sometimes might have the issue with that.
Right.
But
I take my hat off to him.
He's got his own approach for it, his own protocols.
I think it would be good maybe to get him on the podcast at some point as an interesting guest. But yeah, I think the CO2, especially if they're older, I think it's a great idea to send them for that and then come back. If someone, especially people who are watching this, some people will be watching this and all they know is filler and Botox because it's the most common stuff. And so they think that's their answer.
Yeah.
But, and I'm sure you would agree, but please put it in your own words. I think if you've got a lot of laxity and crepiness, fillers is not the thing to start with.
It's not. It's the worst thing. Like I said, you don't want to be treating a bed sheet. You want to be treating a duvet.
Yeah.
A good skin quality retains the product.
Yeah.
Loose skin, like a curtain, it drops, hangs, and doesn't sit properly.
Yeah.
You want to make sure it's retained well. So if they have got loose skin, skincare comes first.
Yeah.
Tighten that, thicken it, bring the envelope back firmer.
Yeah.
Then fill it.
Yeah. And I think there's two perspectives on that. One is if it's quite lax or crepey, do that. And the other is if it's very lax or crepey, I think consider surgical.
Surgical, absolutely.
Yeah,
that's where you recognize your limitations. The other benefit is by doing that, you often need less volume.
Yeah, I was going to say you need less product.
Yeah, so to do the same job. And often, like I say, you could take skin boosters out of the equation.
Yeah.
Because it's been done by the surfacing.
Yeah. And so in terms of timeline, if someone comes to you, they're not in the surgical category, but you know they need a little bit of work, and you think, I'll do that before I do the filler. What kind of timeline are you going to sign away from
I
that for?
actually refer people for surgery first, and I say, look, I'm Plan Z. Go and do that first.
Yeah.
That's my protocol. If they're pre-surgical, they don't want surgery, and they're suitable for, and the face is smaller because remember, filler makes the face bigger.
Yeah.
If they've got a diminished face with a recession, I would treat them then. Probably if they want a delayed facelift,
Fine.
often they go 4 or 5 years later.
Okay.
But I'll maintain them.
If someone has a facelift and they agree to it and then come back to you, let's pretend they've had the facelift today. When are you happy to see them to do
12 months later,
a year
tweaks if needed.
Okay, fine. And are there any kind of treatments that you will not do fillers for afterwards? So for example, some people will just outright refuse someone who's had a facelift.
Yes.
Because they don't know the anatomy as well now.
I think, look, facelifts are nip and tuck. They don't create structure and proportion and balance.
Yeah.
Unless they've had fat transfer.
Yeah.
People who've got a facelift may need tweaks here and there, may need some balancing. I would definitely treat a facelift candidate.
Yeah.
Things I'd be careful with, not always say no, but I'd be careful with, would be somebody who's had like a Lafort fracture and they've got plated screws in the face.
Yeah.
Because the risk of infection and integration is different.
Yeah.
Implants, silicone implants, if you perforate them, rupture them, they don't sit properly, they don't integrate properly.
Yeah.
Surgical lip lift candidates,
Yeah.
they might want more volume.
Yeah.
The risk of VO is high.
Yeah.
Multiple rhinoplasties.
Yes.
Not only is there going to be scar tissue, there's a vascular risk, but try injecting somebody who's had 4 rhinoplasties with a strut, where they're taking cartilage from your rib or your ear.
Yeah.
You can't even get a needle into it.
Yeah.
There's just no point.
Yeah.
Frontoplasties or brow lift, sometimes the vascularity, the frontal branch of the superficial temporal artery could be in the deep plane.
Yeah.
So the risk is high. I'm very careful with those cases.
Yeah.
Blepharoplasty, especially lower lid blephs, doing trough filler, you're gonna create probably lymphatic swelling and probably Małe edema. You could dissect and cause problems.
If there's scar tissue here in the tear
I've actually done that in somebody once, and that was a problem. It took a while, but I got rid of it in the end.
Yeah.
But yeah, I did discover that afterwards.
Yeah.
Scar tissue from a lower lid bleph, especially if they've got proper herniation, it becomes very hard to treat.
It's hard to drain any issue.
Yeah.
That's
they say endolift is effective for that. I've not tried it yet, but
I don't know. I mean, I think endolift, it's, for those who don't know, endolift is like this wire. It's a bit like, to the layman, it looks like a long wire, and there's a light, so when it's under the skin, you know where it is. And I think it emits, it's like a laser basically. And then, you know, you use that to emit the radiation of the laser, and it's supposed to tighten things. I don't know. I think some people do get good results from what I've seen.
Controversial outcomes. Expectations often are higher than outcomes.
Yeah.
One thing I would definitely add with endolift, anyone considering it, is if somebody sells you endolift for volume loss here, don't do that, because your fat pads are inside from the cheek. So bichectomy is a better procedure. Buccal fat removal is better. External endolift is not going to fix that problem. If anything, cause nerve damage. Marginal mandibular nerve damage is very commonly reported with endolift if you're too deep. So you need to go to somebody who's pretty experienced, treats the right. It's very candidate selective. And
100%.
I don't do much of it, but I'm well aware of the risks.
I think it's something
as well.
I've had some people say, you know, I get great results with it, and I think, oh, okay, I've got no reason to doubt that. But there's so many people that are saying it does nothing as well. And I've had patients come to me who have had it and said, I didn't know there's a difference. So I've got
lots of loose skin and you know, they probably need like fat removal and a neck lift.
Not
endolift.
I agree. I think it's, if you are going to use endolift, I think it's just, you just got to go to the right person.
It's a lot of sense and candidate selection. Someone who's all the time recognizes that.
I think Dr. Bayati in London, he does a lot. So if you want someone with a good experience, he's
Dr. Dennis. There's a guy, another one called Dennis Kilman. I can't remember his surname. He does a lot of that.
Okay. I mean, in the UK,
in London, Harvey Street.
Okay, fine. Yeah.
I think he's one of the leading KOLs.
Okay, for the device.
Endolift,
Any of the devices or treatments that you refer people to, you know, for the skin rather than the actual volume?
Morpheus, in some cases, very elect few. But my only issue with Morpheus is it eats away the filler. It destroys a lot of that.
For me, as pre-filler
pre-filler.
Before anything, if possible.
Oral therapy, again, very selective candidates.
Yeah.
I'm not a big device guy. I think you've got to be very selective, very selective, and have your expectations managed.
Yeah.
I think realistically, skincare, like quality skincare with laser instruments, work wonderfully.
Yeah.
Volumetric balancing and facial support with dermal fillers work wonderfully.
Yeah.
And then select candidates, skin boosters work.
Yeah.
You need many of them.
And I think I would add to the list for my personal practice, home care, not just skincare, but home LED therapy.
Yeah, I've never tried that, but my wife does a lot of that.
Which one does she use?
She's got the red LED mask, the big device one, the machine.
Dermalux,
yeah.
Best one.
Not a fan?
Best one.
All right.
If for clinic level power, I would never have anything other than Dermalux. For home use, which is obviously going to be much less power, but accepting that, I would probably go with the Style Pro.
Some people do that with Hydrafacial, don't they? They'll put you on a mask and then Hydrafacial afterwards.
But then the one in the Hydrafacial, I think it's like they do the probe for the Hydrafacial, and then they've got another probe with a light on the end, and then they rub that. Is that not how they do it?
No, they do the Hydrafacial and then they put the mask afterwards.
They put like a dermal
mask after.
Fine.
Yeah.
So the issue with that, so when you have a Hydrafacial, right, what's happening is that probe is going to cause, trauma to the skin to an extent, because you are firing things in there and you're pulling things out as well. Now, if you're causing enough trauma to actually put things in the skin, frankly, afterwards, what's stopping pathogens from getting in there as well? No one answered that. But anyway, you put that in there, there's a small level of inflammation, hence why people look red, okay? They walk out the shop thinking, oh, I've got this glow. No, you haven't got a glow. You've got a glow in the same way that Mike Tyson had a glow when he got smacked in the face in the ring. You're inflamed. But in aesthetics, we reterm that word as a glow to sell. But realistically, it's inflammation. Yeah. Now, that level of inflammation, there are inflammatory markers in there, in the skin now being released, interleukin-1, beta, interleukin-6, TNF-alpha, etc. If you then put red light immediately afterwards, what you're doing, that red light is going to hit a protein called cytochrome C oxidase. If that then works on the oxidative phosphorylation process to increase the level of activity that's going on, but the level of activity is inflammatory, you're actually increasing the inflammatory activity, therefore the level of inflammation potentially. And your skin, when it's trying to improve, in the world of aesthetics, will be this or in injectables, it can either work by homeostasis, i.e. natural, nice, healthy work, physiology, or inflammation. You're always going between the two. If you do stuff here, you're limiting what you can produce. Hence why nearly every skin booster in the world only makes type 1 and 3 collagen. And if you're inflamed at that point, and you then increase that inflammation potentially with the red light, you're staying in this even further.
Right.
And, there's a video on my channel where I actually interviewed a patient of mine who very kindly agreed. She had quite severe acne. And I referred her for LED, and I wrote the referral, wrote the protocol that was needed. And I said, do not use red, use blue and near infrared. They didn't do that. And I know because the patient saw the red, and even when they walked out the shop, straight away, the acne was worse.
Right.
And they never went back. And I said, I'm so sorry they did that, but let me refer you again to someone that I can have a call with and get them to lift them to me.
Right.
Yeah.
Yeah.
They did blue and near infrared.
Improved it.
Within 1 day, it was better. Because the red is not the miracle worker that people think it is. It can be, but it can also cause harm if it's used inappropriately.
Right.
So if it was Hydrafacial, I wouldn't use it. That's reason number one. Number two, you've got remnants of chemicals on your face now. What are they going to turn into when radiation hits them with sufficient amount of energy? They are going to, they're going to cleave at a certain point. So if you take unsaturated fats that make up your cells, for instance, the reason they can release, the reason I think they're going to cause pigmentary issues is because those 4 electrons, it's a double bond, they can form a bond with something else now and leave 2 behind to stay connected to where they were. So if you have molecules, let's be honest, I don't think Hydrafacial is that transparent in terms of what's in there. I sent them an email years ago saying, can you tell me more details of what's actually in there? I never got a response. So if there's things in there that potentially do have double bonds or maybe have a weak energy requirements to break one particular even single bond, and the radiation is then being put on the face, it hits that, breaks it down, and then hits something else and whatever. How do you know what's happening in the skin? It's very important that whenever LED treatment is done, that it's on clean and dry skin, because then you know it's actually going to what you want. The third point is you're limiting the result.
Yeah.
Because LED needs to reach the skin. If you've got a layer of stuff on there, you're getting refraction of that. And it's potentially not going to reach the target properly. And a level of that radiation is being absorbed now by the layer on top of your skin instead of the skin. So what's the point?
Right.
So you're actually reducing how you're using LED because you want all the power it can produce to go into your skin. But if you've got a barrier there, and by the time it hits that, some of it's gone and then less hits your skin, what's the point?
Right.
You actually get more of a result doing LED later on in the day.
Okay.
Once it's all clean and used up. Welcome back. Had a lot of toilet break there. We don't normally do cuts, but I've spiked him with a lot of water today, so he's had to empty himself. So we've just finished talking about Hydrafacial, LED after Hydrafacial, things like that, and in the context of what kind of care people do at home to maximize the quality of the skin so that you as an injector can do a better job for them in the clinic. Another thing that people are tending to do at home now is look at the whole longevity field, the actual sort of anti-aging field, rather than just topical local things. I think we're seeing a lot of injectables,
Mhm.
such as, NAD, peptides, all that kind of stuff. Are your patients, are your filler patients coming and talking about these things to you at all? And if so,
Yeah.
what specifically?
Yeah, I mean, look, the word peptides have been mentioned a few times. I know they work on the cellular level.
Yeah.
I know that's big in the US as well. But again, this whole Looksmaxxing trend, the word peptides comes up all the time. So tell me what
Right.
you know about these and
Yeah.
your experience with peptides.
So peptides, for those that don't know, a peptide is basically a chain of amino acids that is a given length. And depending on the size of the length, the amount of amino acids, it might be an oligopeptide or something like that, or it might be a tripeptide where it's just 3 amino acids. Technically, glutathione, our internal antioxidant, is a tripeptide. It's glycine, cysteine, and glutamic acid. So different peptides all are based on amino acids, but different amino acids in different orders, in different numbers. And each one is, so there's like an unlimited number of combinations that you can get. And each one has a specific property. So for example, if you've got something, each amino acid has a base. Let's say the base is this bottle that is always the same, but maybe you've got a different colored lid for each one. So I mean that the side chain on amino acid is very different. One lid might be in the shape of a hand, in which case that'd be useful to do a high five with someone. Another lid might be completely flat, or might have a sports lid, so you can use it without having to take the whole thing off, etc. They've all got different properties as a result of the side chain. So based on what the side chains are, the whole thing has a different property. So if the side chain is very hydrophobic, it's going to work in a particular way in a particular place. And as a result of that, every peptide is completely different. Even the weight loss drugs that we see nowadays, they're peptides at the end of the day. GLP-1 agonists like Ozempic, Wegovy, Mounjaro, blah, blah, blah. Liraglutide, semaglutide. This is a type of peptide therapy, if you like, working on these receptors. Now, because of how varied they are, I think it's very difficult to talk about all of them in a blanket way. But there are certain peptides which seem to be very, very promising, or potentially very promising. So, for example, a lot of anecdotal evidence, keys anecdotal, in things like BPC 157, which is a very sort of repair-oriented treatment. You might also see something like GHK-copper, which I think is a little bit more relevant to the field that we're in now.
Are these more topically or injectable?
I mean, GHK-copper can be topical. The issue with it being topical is the stability. How do you ensure that the GHK, each of those letters in amino acid, so glycine, histidine, and lysine, even though lysine begins with an L, it's a K because I've got leucine as well. So it's a glycylyl, histidylyl, lysyl, copper. And the copper has, all three of those when together have a high affinity for the copper, so they're very tightly bound. How do you know that's still tightly bound in an unstable, potentially unstable skincare formulation, which is an issue, and in the penetration as well. So you can do topical, but you've got those issues. The pro is it's not going to affect the body because it's only topical, but you can also inject it subcutaneously, or even in an IV. The problem with that is, if you go overboard, you're going to get copper toxicity, I would suggest, because there's only a certain amount of copper that you have. And is it going to give you a nutrient deficiency? Because copper and zinc compete for absorption in the body. Hence why if you look at a good quality multivitamin, if you need it for a certain situation, or that I recommend them, you might have copper in there. But that multivitamin will also not have zinc or magnesium because of the inhibition that's there. And you have a separate ZMA product versus a multivitamin. A good multivitamin is actually limited because they understand competitive absorption or inhibition of absorption, and they have everything else separately. So if you inject that copper, GHK copper, and you do it IV, that copper that's there, if you have that close to a meal, and the meal is a good amount of zinc, maybe it's some beef, some oysters, whatever, that copper could inhibit the absorption and the bioavailability, and therefore utilization of that zinc. Now, let's say someone has low testosterone, low in terms of symptomatically speaking, not necessarily what a piece of paper says in a reference range. If they do, could it be because there's a zinc issue? Potentially, I don't know, but let's pretend it is. And then they go and get themselves a GHK copper IV. Well, they've just exacerbated their zinc issue. So the issue with peptides for me is the interactions with everything else. I'm not saying they're bad or they're unsafe.
And if they're not clinically deficient as well.
Yeah, exactly. And you've also always got to ask, if you make your body do X, Y, Z, it's going to use resources for that.
Got it.
And it chose not to by itself, and you've put it there. And your body always does the best it can to keep you alive. Every decision it makes is the best decision. Otherwise, none of us would have evolved to what we are today. So if you're diverting resources to that, what are you taking the resources away from?
Yeah.
And there's an opportunity cost question, which I've never seen anyone talk about. let's say, for instance, hyaluronic acid. People talk about hyaluronic acid being this hydrating thing, right? It's not bloody hydrating. It's not hyaluronic acid that's actually hydrating things. It's the metal. Because again, without being too nerdy, on the top left side of hyaluronic acid, there's a carboxylic acid group. One of these hydrogens is lost, and which is what makes it an acid. And you get this electron density spread across two sections, which makes it a polyelectrolytic chain. That attracts a positive metal ion like sodium. Hence why on a pack of HA, it will say sodium hyaluronic, not hyaluronic acid. Actual hyaluronic acid is very rare to find. And it's the sodium, which is positive, that attracts a negative end of the water. And fine, you're attracting some water in a shell. It's called a stellate shell or a hydrate shell. But that water's been taken away from somewhere else now. So there's no net hydration. There's a movement of water from there to here. That's it, which means that place, at least temporarily, while it's being moved away, is now deprived of the water.
Right.
So when you use peptide therapy, you've got to ask, what is the opportunity cost? And again, it doesn't mean it's an automatic, no, don't use it, it's terrible. It means just have that thought and understand it. Because sometimes it might not be that bad, in which case, fine, go ahead. But be aware of it and don't go overboard with it. At GHK-Copper, I remember reading on some post somewhere, someone saying, I've been doing this, I think it was like once a month or once a fortnight, something ridiculous. And then they listed some problems. I was like, well, those problems sound awful like micronutrient issues. And you're giving yourself potentially copper toxicity here. So you need to draw the connections.
Do you think people should be having blood tests first to screen?
If it was me personally, yeah. And not because the blood test is going to dictate any treatment, but because you have a baseline to compare.
Right. And you don't, if you're not deficient in it, why would you incorporate anybody?
Exactly.
It'll mess up.
And I would do at least 2 blood tests. Because if you eat a meal and then you go down to a clinic, that blood test can be completely different than if you've not eaten since the morning and then you go and do it. So you need to do multiple blood tests. Hence why in TRT they do multiple blood tests. Or do multiple blood tests. And the 24 hours leading up to it, or maybe the 48 if possible, my diet and lifestyle should be identical. So either if you trained 12 hours before the test last time, train in the same way, same exercises. But if your last meal was 8 hours before, make it 8 hours before. Eat the same thing, etc. So you have that reliability. Otherwise, even the blood test isn't reliable. And even the time of day that you do the blood test needs to be the same. Once you have that baseline, then if you want to track things, fine, track. But then when you do the blood test while you're on the peptide therapy, my advice to people is, again, copy that same 48 hours and then do the blood test. And then you can figure out what's going on. One issue that we have is a lot of these peptides, well, nearly all of them actually have no long-term data, which is understandable. I get it. And sometimes you've got to just do it and you figure out as you go along. That's fine. But I'm saying that from the perspective of some peptides I don't think will need long-term data, potentially. Like some of them are just repair. So if you just have them now and again, you're not going super physiological on any level, you're just repairing. There's a difference between super physiologically increasing the level of something like copper versus not increasing the level of thing, just causing repair to damage, which is fine. And this is what makes peptides so difficult to talk about as a broad category. They're doing the opposite of each other. One's going super physiological, one's restoring physiology.
Right.
And so you have to categorize them into these categories. So something like, a cardiolipin repairing peptide, which is going to restore the curvature within the mitochondrial inner membrane to make sure cristae have good function and structure. If you repair your mitochondria, how is that a bad thing? It's fine. As long as, there's purity in it, it's not got rubbish in there. Whereas if you take the GHK copper and you go forward with that, as we know, copper toxicity is a realistic thing.
Yeah.
So peptide therapy, I think, can be great. We're figuring out now which peptides.
More data, more evidence.
Yeah, and it's based on basically anecdotal data, which, sometimes that's all you got, in which case, fine, go for it. Like, we spoke earlier about there's no data on dissolving, in certain situations, or filler blindness. We've only got anecdotes. Yeah, we're limited inherently with what it is from anecdotal only, at least for a long time.
Yeah.
So I think peptides, if you want to add it to your practice, I would say, yeah, look into it and it's worth it. And I have used some, I'm not going to say which, but I've used them in patients as well to tremendous effect. But under strict clinical supervision with blood testing before and strict monitoring, touch wood, I've never had any patient with any issues whatsoever. People who just go willy-nilly.
That's where the problem starts.
Yeah, exactly. And that's the issue. Have you tried any yourself?
I haven't, no, but
okay.
Like I said, I hear about it all the time, just haven't incorporated it.
And so where do you, if you heard about it, obviously, you're in a mind to always think about what's coming in the future. And I'm sure you agree that it's going to get bigger and bigger. What other things do you see in the future of our aesthetics, our cosmetics world over the next, pick a time frame, year, couple
I'd
of
like
years?
to see a movement come
Yeah.
back to, artistic, the scientific artistry model of scientific artistry
Yeah.
applied to injectables. People knowing how to do it properly.
Yeah.
Because I think what's going to happen is there's a big push towards regenerative work, and
Yeah.
while it has its place, it's good.
Yeah.
It doesn't replace the deep structural foundation of volumetric frameworking of the face, the architecture of the face. A common scenario is, people often do the polynukes for the eye and then realize 2 weeks later it's disappeared.
Yeah.
You're not really restoring volume. Working on a profile balance or, non-surgical rhinoplasty.
Yeah.
The movement away from fillers is actually detrimental because people think that the alternatives are going to work. When in fact, I'd like to see a movement go back to it being done well. And I think we're going to go through a movement. This industry, you're going to start to filter out what's bad and what's good, and recognize that those of us that do it really well are really pushing the boundaries and really making sure that it's got its place to stay.
Yeah. I think it's the idea of silver bullets.
Yeah.
People just jump from what they think is a silver bullet to the next thing.
Trends need to disappear.
Yeah.
This idea of just jumping on a trend.
Exactly.
They shouldn't replace the fundamentals of structural framework in the face, which fillers have done for years.
And the aesthetics industry is notorious for trends. It's always something new. It's always me being cynical, and then I'm proved right a while later.
We need to do more of what you're doing, calling people out.
Yeah.
Backing it with data.
Yeah.
Not just anecdotal, but things that worked and proven to work.
Yeah.
I think more of that needs to be
definitely. And I think people don't do it because they don't have the ability to read scientific papers properly.
Yeah.
In fact, I was just talking to Tim Pierce.
Yes.
I was just chatting to Tim, I think last night or this morning, and I was just saying, he said, "Oh, I saw your post where you're talking about going back to basics and fundamentals of science." And I said, "I've never seen anyone analyze something like that." And I said, "Well, yeah, no one teaches it, which is a problem." And I think, the trends in the aesthetic world always are there. And I think social media is a big factor as a result. We're seeing things like polynucleotides, exosomes, random things like that. They're going to come and go. Like even the weight loss drugs. I said years ago, look, this is going to cause all sorts of problems. People are going to have intestinal problems.
It's happening.
What a surprise.
It's happening.
Exactly what I said has come true. And I remember once I put it on my story on my feed, and someone who was in a Facebook group sent me a message, a screenshot. Look, they're talking about you on this group. They're calling you out. He doesn't know what he's talking about. He's scaremongering. It's nothing. He's a dentist. And then I think a few months later, a story came out, 1,800 lawsuits worth $2 billion or whatever, with all the problems.
Wegovy.
Every single thing I said in my post on Instagram or still in my account somewhere came true. Think back, none of you had any idea how to read a paper, and you have no idea what you're doing. For me, what I want to see is a back to basics approach of how to actually look at scientific experimentation. No one can read a paper. If you can't read a paper, you can't look at evidence. If you can't look at evidence, you have no idea what is evidence based and isn't. And I think that's why people pick crap products.
True.
There are crap fillers out there. There are crap skin boosters out there. There's crap skincare. If people knew the science well enough, they wouldn't fall for it. I'm proud to say all the graduates that I've taught, I'm not a university obviously, who I've taught, never fall for those things again. And they then teach what I teach them to other people too. And this wisdom hopefully is spreading. But I think for me, it's got to be about the education and the quality of it. And that's one reason I want to get you on, because you're so big on education everywhere. How can people, learn from you? What if people want to do a one-to-one? Do you do one-to-one? What if they want to?
I do. Time is poor at the moment, but look, the best thing to do really, if people want to learn, I do small group sessions, I do big group sessions, and I travel to people as well if need be. But the best thing really is the facial sculpting masterclass, because I go into real heavy detail on geometrical proportion.
What's the format of that?
So the morning when they purchase the course, they get access to my ebook. The ebook is all about facial assessment, convexities, all the stuff I mentioned earlier. So they have a baseline of what to assess. On the day, I go into a bit more theory with examples and case studies than a live demo. And then the whole day, we cover the 4 types of patient we see in practice. The male, the female, the profile, and the mature face. Who's not ready for surgical, but pre-surgical case. We do cover complication management to the level we discussed. But more so learning the theory and applying the science. But they have to be an advanced level injector.
Of course.
Can't be basics.
What kind of minimum experience level would you expect to come and learn from you?
Have to have needle and canyon experience, at least 5 years of injecting, or treated more than 40 to 50,000 patients.
Okay, fine.
So you need to have the base. This is not to teach aesthetics from the beginning. This is to refine and adapt. And optimize your technique.
And in terms of the one-to-one, Is that something you do commonly now? Like I said,
I'll be honest,
is for.
I'm trying to do less of that.
Okay.
As and when I can, if I have a day or so, I probably will give time. But it's a lot of effort to organise a one-to-one.
Slows down appointments because you've always got to explain everything, and
Right.
you know they've got to make up to your
getting the
income.
right models, vetting them, verifying them.
Yeah.
It's a lot of it's sometimes not worthy of the time.
Yeah.
But the small group sessions certainly are for me.
Yeah.
And great value for you guys as well.
In terms of the small group versus big group, what numbers are we talking?
6 to 7 people maximum.
Okay.
And lots of hands-on.
How do they book that?
Online, sculptclinic.co.uk, or you can just follow my Instagram page, Dr Zack Ally.
Yep.
There's always links in the bio.
Yeah. You started a new account, didn't you?
Yes, I did.
What number did you get up to on your older one in terms of followers?
174,000.
874,000.
174.
174,000.
I wish I had 870. Yeah.
Oh, what are you on? You're on probably about 100 now?
No, 20 odd thousand, 21,000.
21,000. Interesting.
Yeah,
okay. I'm sure that will grow.
For me, the number is not important. The quality is important.
Yeah.
I don't buy followers. I'm here to.
No, you definitely don't. Well, the only reason I ask because I think what you do fantastically, which a lot of people don't know how to, is social media. And you don't have to. I was going to agree that you don't have to have huge numbers of followers. Quality, not quantity.
Absolutely. I've always been
100%. Yeah. So in terms of the UK, if people want to come and see you to get personal treatment, do they go to the same place, Sculpt
Same
Clinic?
place, Sculpt Clinic. I'm based in Wimbledon and Dubai.
Yeah.
And
Wimbledon and Dubai.
Days, yeah. But yeah, through the Instagram or the bio, usually the link is there.
And I want to finish off with a kind of like a happy piece. I would like you to give some shout outs to clinics or individuals that you think just do stellar jobs, surgical, non-surgical, whatever. Because some people may be in a country, maybe in the US, and they can't fly to come see you, or they can't come to fly to see you in Dubai or something like that. Maybe you could suggest some great people around the world that you think are really good at what they do.
Okay. If we talk about honesty, integrity, good skill quality, really have taken this and mastered it.
Yeah.
Jacob Sanchez over in Miami, very proud of him. He's done incredibly well.
Yeah. Is he surgical or non-surgical?
He's non-surgical.
Okay.
Nicola Lowry over in LA, very, still till this day, 30 odd years experienced.
Yeah.
Still investing in education.
Yeah.
Calls out BS all the time.
Fantastic. Sounds like my kind of person.
Yeah. Again, hats off to Bass and Band in London. He's done really well. He's mastered it. He puts lots of time and effort in his work.
He does.
Ayod Hub for his approach to the nose. I love what he does.
Yeah.
Learned a lot from him. And yeah, leaders in the field like Arthur Swift, who use science to educate us, and don't just talk about what their experience is, but you often back up with research.
Yeah.
So a big fan of him as well.
And is there any other people in the, obviously you mentioned Arthur, any other kind of educational people that you think are really good that
all of those guys are educational.
Okay, they teach as well, all of them.
They educate in their parts of the world.
Yeah.
Small and big scale.
Okay, fantastic. Brilliant. Well, Zack, this has been incredible. There's actually other things in my head I want to talk about, but I don't want to keep you forever because I think we'll be going for about 6 or 7 hours.
Sure.
Maybe later in the year you can come back, we can do another chat or something like that. That'd be brilliant. And if you're doing a course at some point before this goes out, I could maybe, if you're in London and you're teaching.
11th of February is my next one.
So if I get a little bit of footage, maybe we can put it in here for people to see as well. But overall, amazing conversation. Thank you so much for coming.
Thank you for inviting me. Thank you.